Okay. So, hello and good evening, everyone. I hope my video and audio is good. Good evening to all dear students. Can you please let me know in the chat box if my audio and video is good so that we'll start. Good evening, Dr. Said, Ruturaj, Deepak, Neetu, Madhuvati, Arun Kumar. Good evening, everyone. Okay. So today we'll start the session without wasting any time. We will be having a very crisp and concise, rapid revision of medicine. So this is mainly for the students preparing for the FMGE exams. So this will be a concise discussion of entire medicine. Okay. I hope all of you have got the soft copy PDF of the workbook. So the unannotated PDF has already been shared, and you can see that in the link provided. So this is a very important session, and you can write down the notes along with the lectures as I'm teaching you. So this will be the QR code of my academic Instagram page. So you can stay updated with MCQs, certain clinical scenario-based videos in this academic Instagram page. Anu, yes, this will be an important session for FMG exam. Okay, let's get started. And as I said, I'll try to keep it very concise and crisp. Okay, let's start. So first of all, we'll start with some basic topics in neurology. So we'll be going in a system-wise order. Again, most important stuff only. I want all of you to be active as well in the comment section. So the first slide is regarding certain important epilepsy case scenarios that can come in your FMG exam. First scenario, a patient with drug-resistant epilepsy. You have given drugs, but the epilepsy is not under control. And when you did the MRI of the brain, what is the finding? There is a problem in the hippocampus. What is the problem? The hippocampus is very small. It is atrophic. So what is the diagnosis here? The diagnosis is MTLE. Can you tell me what is MTLE? MTLE is mesial temporal lobe epilepsy. Mesial temporal lobe epilepsy. Mesial temporal lobe epilepsy is the diagnosis. Okay, mesial temporal lobe epilepsy, very important. So what is the treatment of choice for this condition? Is it anti-epileptic? No, it is surgery. What surgery? Amygdalo-hippocampectomy, very, very important. You will remove the amygdala and a portion of the hippocampus. That will be the treatment of choice, surgery. Next scenario, number 2, if patient is having absent seizures and EEG shows 3 Hz spike and wave pattern in the EEG. And suppose the age of the patient is between 4 to 10 years. Absent seizure is a type of seizure. Can you tell me which is the epilepsy syndrome that can present with absent seizures in the age group of 4 to 10 with EEG showing 3 Hz spike and wave pattern? Diagnosis is childhood absence epilepsy. The short form is CAE. It is childhood absence epilepsy. Important MCQ. Childhood absence epilepsy. So the absent seizures, it is often, the symptom will be child is daydreaming in the class. The child is daydreaming in the class. The third epilepsy syndrome. So we are done with 2. Third is patient having myoclonic seizures and also GTCS, generalized tonic-clonic seizures, and the EEG is showing 4 to 6 hertz spike and wave pattern. Can somebody answer what is the diagnosis? Myoclonic seizures are there and you're having generalized tonic-clonic seizures. So I'll just give you a clue. The age of the patient is around 12 to 18 years. 12 to 18 years with this epilepsy syndrome. What do you think is the likely diagnosis? What is the likely diagnosis? It is JME. What is JME? JME is juvenile myoclonic epilepsy. Very, very important. This is a PYQ also. Juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy. Right? Done. Now, next epilepsy syndrome. Patient having epileptic spasms and EEG showing hips arrhythmia pattern. What is the diagnosis? It is West syndrome. EEG showing hips arrhythmia pattern. Diagnosis is West syndrome. Okay, important, West syndrome. Okay, right. Next scenario, patient with drug-resistant epilepsy. We already learned one drug-resistant epilepsy, which is mesial temporal lobe epilepsy. Another drug-resistant epilepsy, but EEG is showing less than 2.5 hertz spike and wave pattern. So what is the diagnosis? The diagnosis is LGS. What is LGS? LGS. That is Lennox-Gastaut syndrome. Lennox-Gastaut syndrome. You can try anti-epileptics, but many of them are drug resistant. You can still try anti-epileptics. Next is patient with epilepsy, low intelligence and adenoma sebaceum. This is a famous mnemonic. Low intelligence and adenoma sebaceum. Epiloia, with MRI showing cortical tubers. What do you think is the diagnosis? It is tuberous sclerosis. Tuberous sclerosis. So these are the important epilepsy syndromes you should know for the FMG exam. Very, very important table. Very, very high yield table. So whatever I am teaching you today, they are all very, very high yield points. Okay, please take special note of this. Next, another important table on the different types of Parkinsonism. I'm writing their unique features and then you have to tell me the diagnosis. So if patient has asymmetric symptoms, okay, asymmetric Parkinsonism. So it's on one side, or if it is bilateral, it is more on one side. That's called asymmetric. So if patient is having asymmetric Parkinsonism, it means Parkinsonism either on one side of the body or both sides, but more towards one side with the typical trap features. That is tremor, rigidity, akinesia, and postural instability. What is the diagnosis? IPD. What is IPD? Idiopathic Parkinson's disease. And what is the abnormal protein that is accumulating? Very good. It is alpha-synuclein. It is alpha-synuclein. So you've got alpha-synuclein and there is Levy body formation. Correct? Levy body formation. And this would be your idiopathic Parkinson's disease. The remaining 4 conditions I have listed, they are atypical Parkinsonian syndromes. Out of the 4, 3 of them have symmetric Parkinsonism. 1 of them have got asymmetric Parkinsonism. So can somebody tell me which condition presents with asymmetric Parkinsonism, especially when it has a unique feature that is alien limb phenomenon? Please think of CBD, that is corticobasal degeneration. What is the abnormal protein? Answer, tau protein. Okay. If there is symmetric Parkinsonism and patient is having recurrent backward falls and vertical gaze palsy, this is unique feature of PSP, that is progressive supranuclear palsy. Very good. I can see all of you are rightly answering. Dr. Mohammed Anash, Anirudh, Sean Parker. Yeah, very good. So what is the protein that is accumulating? Again, tau protein. If patient has significant autonomic dysfunction, please think of multiple system atrophy. What is the protein accumulating? Alpha synuclein. Alpha synuclein. If patient has Parkinsonism, dementia with visual hallucinations, very prominent dementia with visual hallucinations, diagnosis, dementia with Lewy bodies. And what is the abnormal protein accumulating? Again, alpha synuclein. Alpha synuclein. Again, very, very important table. Okay, very, very important table, right? Done. Let's next quickly go through the various gait abnormalities seen in various neurological disorders. Fascinating gait is seen in IPD, that is idiopathic Parkinson's disease. Okay, and what about high stepping gait? It is seen in foot drop. In foot drop, you get high stepping gait. Stamping gait. Stamping gait happens when there is defective proprioception. So it is seen in conditions like sensory ataxia, where proprioception is defective. Drunken or reeling gait is seen in cerebellar disorders. Cerebellar disorders. Magnetic gait is seen in NPH, that is normal pressure hydrocephalus. Circumduction gait is seen in hemiplegia. And waddling gait is a feature of myopathy. Waddling gait is seen in myopathy. These are the important gait abnormalities. As I said, I'm going to keep it very concise and crisp, but each point that I'm discussing is a potential question for FMG exam, right? Okay, let's go to the next slide. So in your neurology and also pathology, one favorite area is trinucleotide repeat expansion disorder. So let me see who's going to answer from the comment section. What are the trinucleotide repeats associated with these disorders? Number one, myotonic dystrophy. Correct, Dr. Ajit and Dr. GV. It is CTG repeat expansion. Huntington disease is CAG repeat expansion. Friedreich's ataxia, GAA repeat expansion. Okay, GAA repeat expansion. And spinocerebellar ataxia, there are different trinucleotide repeat expansions, but the most common one is CAG. There are certain others as well, but most common is CAG. And Fragile X syndrome is CGG. Fragile X syndrome is CGG. Important, right? Okay. Next table, again, high yield table on disease and drug of choice. Question, drug of choice for Parkinson's disease. Answer, levodopa. Drug of choice for levodopa-induced dyskinesia. Answer, amantadine. Drug of choice for off episode in Parkinson's disease. Answer, COMT inhibitor. Catechol or methyl transferase inhibitor. Drug of choice for severe off episode. So if they are asking in question off episode, which means patient is having symptoms, but it is not very severe. So you can add COMT inhibitor to levodopa. But severe off episode, COMT inhibitor is not enough. So what drug? Correct. Sean Parker, you are right. You will give subcutaneous injection of apomorphine. Very good. Drug-induced Parkinsonism. What is the drug of choice? You will go for anticholinergic. Anticholinergics like trihexyphenidyl, benzhexol, okay, benztropine. You can go for anticholinergics. Then restless leg syndrome. This you have to be careful. Some years back, we used to give ropinirole and pramipexole. Even now, we can give ropinirole and pramipexole, but the drug of choice now is gabapentin inacarbil. There is a salt of gabapentin, that is gabapentin inacarbil is the drug of choice. Acute severe migraine episode, drug of choice is triptan. Drug of choice for migraine prophylaxis is beta blocker like propranolol. Okay, but if patient is having asthma, you cannot give beta blocker. What is the drug of choice for prophylaxis of cluster headache? Answer, Verapamil. Verapamil is the drug of choice. Verapamil. What is the drug of choice for prophylaxis of paroxysmal hemicrania? Not only paroxysmal hemicrania, for hemicrania continua also, the drug of choice is indomethacin. The drug of choice for prophylaxis of SUNCT/SUNA, answer lamotrigine. Answer lamotrigine. Drug of choice for prophylaxis of trigeminal neuralgia is the sodium channel blocker carbamazepine. So these are some important disorders in neurology and the drug of choice. Can you tell me what is drug of choice for certain of the, I think it's coming in the next slide. What is the drug of choice for typical absent seizure? If question is typical absent seizure, drug of choice is ethosuximide. If question is atypical absent seizure, drug of choice is valproate. But if question they are asking either simply absent seizures or they are seeing childhood absence epilepsy, answer is ethosuximide. Ethosuximide. Okay, very good, very good, very good. So this you should not confuse. Let me ask you one question which, let me see how many of you are able to answer. Suppose you get a question that patient is having both absent seizures and generalized tonic-clonic seizures. Okay, can you tell me what is the drug that can be used? Both absent seizures and GTCS. Very good, it is valproate. In that scenario, you cannot use ethosuximide. Ethosuximide is only useful in absent seizures. Janvi is asking, sir, I had studied nothing from medicine. Is this enough for upcoming FMG exam? Dr. Janvi, in this session, I am covering the most high-yield content. So there is a good chance that you will get good number of questions from this session because whatever I am giving you is in simple point-wise form. So it is easier for you to learn and you will get good number of questions from this as well. What is the drug of choice for juvenile myoclonic epilepsy? Answer valproate. Answer valproate. Good. Okay. Dr. Saurabh is asking, is there some audio glitch? Can you tell me in the comment section? Is there any problem with the audio? Is there any problem with the audio? Please let me know in the comment section. No, Saurabh, it must be a problem at your end. Please take care. So next, if the question is drug of choice for epileptic spasms in West syndrome, answer is intravenous ACTH. Drug of choice for epileptic spasms in tuberous sclerosis, answer vigabatrin. Answer vigabatrin. Okay, very important. Okay. Now, can you tell me what is the drug of choice in Lennox-Gastaut syndrome? Lennox-Gastaut is difficult to be controlled with anti-epileptics, but you can try one anti-epileptic. What is that? It is valproate. See, I want to tell you, I know that many of the students, you are all a bit anxious, nervous, listening to, last few months, you are reading multiple textbooks, multiple notes. Please don't worry. Stay relaxed. All of you have put good effort. You only need to revise properly. That's the only thing you need to do. Stay calm and relaxed. If you are more relaxed, when you see a multiple choice question, you will think better. When you think better, you will answer better. So don't worry. Okay. Somebody is asking, sir, how can I complete entire medicine? Don't worry. That's why we are doing these rapid revision sessions to concise big subjects. Okay. Please do not worry. Right. Now, what is the drug of choice for acute episode of multiple sclerosis? So if patient is coming with multiple sclerosis, having an acute episode, what is the drug of choice? You will go for steroids. Which steroid? Intravenous methylprednisolone. Intravenous methylprednisolone is the drug of choice. Okay. What is the drug of choice for Wernicke's encephalopathy? You will give high dose intravenous thiamine. High dose IV thiamine. Okay, right. That's it. So this is again Two very important tables on the drug of choice for various neurological conditions. Very, very high yielding. You may get question from pharmacology also related to this. Okay, right. Next, some important imaging and the diagnosis. This you can expect either as medicine question or medicine overlap with radiology. Hot cross bun sign seen in multiple system atrophy type C. Putaminal rim sign seen in multiple system atrophy type P. Hummingbird, Mickey Mouse sign, penguin sign, morning glory sign. All of them seen in one condition. What is that? Can you tell me, Dr. Anirudh, Aishwarya, can you tell me what is that condition? It is PSP, progressive supranuclear palsy. Face of giant panda sign seen in which conditions? Wilson disease. Wilson disease. Temporal and parietal atrophy, especially atrophy of the medial temporal region. Can you tell me which dementia is associated? It is Alzheimer's disease. Alzheimer's disease. Alzheimer's disease. What about boxcar ventricles? Where do you get boxcar ventricles? Where there is atrophy of the striatum. Which condition? Huntington's disease. Huntington's disease. Eye of tiger is seen in which condition? PCAN. What is PCAN? Pantothenate kinase associated neurodegeneration. So PCAN is pantothenate kinase associated neurodegeneration. It is also called Haller-Warden-Spatz disease. Okay. Dawson, the hyperdense MCA sign is seen in acute ischemic stroke. In acute ischemic stroke, you may get hyperdense MCA sign. Correct? Hyperdense MCA sign. Very good. Dawson's fingers are seen in multiple sclerosis. Multiple sclerosis. Okay? Right. Can you please let me know if my speed is okay? Can you please let me know in the comment section if my speed is okay or not? Okay, in app terms, should I go a bit more faster or is it okay or should I go slower? Okay, I hope it is okay. Yes, I can see most of you in the comment section. They are saying speed is okay. Right. Next, let us quickly see what are the intracranial hemorrhage patterns. Very simple. Biconvex shape, EDH. Okay, biconvex, EDH. Okay, crescent shape, it is SDH. Okay, and this one, starfish appearance, subarachnoid hemorrhage. You get a starfish sign when there is bleeding in the various cisterns, creating a starfish appearance. And the last one will be a intracerebral or intraparenchymal bleed. Intracerebral hemorrhage. Okay, good everyone. Very good. Well answered. Coming to the other radiological signs, inverted V sign. Can you tell me which vitamin deficiency? Answer, vitamin B12 deficiency. Vitamin B12 deficiency. Cortical ribboning, hockey stick sign and Pulvinar sign. All of them seen in Creutzfeldt-Jakob disease. Trident sign. Let me see who answers this. Slightly difficult, but let me see who's able to answer. What is a trident sign? It is an MRI sign of which condition? Can I give you a clue? This condition happens when there is rapid correction of hyponatremia. When there is over-aggressive correction of hyponatremia. Can you answer which condition? Over-aggressive correction of hyponatremia. It is CPM, that is central pontine myelinolysis. Too rapid correction of hyponatremia can cause damage to myelin. This condition is called central pontine myelinolysis. Basal exudates are a feature of tuberculous meningitis. Tram track calcification. Who's going to answer? Anirudh, Divya, Jay, Sean, can you tell me? Tram track calcification. Finding in which condition? It is seen in tram track calcification. It is seen in Sturge-Weber syndrome. It is seen in Sturge-Weber syndrome. Sturge-Weber syndrome. Starry sky appearance in MRI. Which condition? Starry sky. I'll give you a hint. It is a neuro infection. Okay, very good. Sean, right. It is neurocysticercosis. Neurocysticercosis. Okay, right. Sean, I think I remember seeing you in Chennai. If I'm not mistaken, your actual name is not Sean Parker, but something else. But I remember, you were in the Chennai class, if I'm correct. Okay, right. Right. Let's go to the next one. Some important neurological condition and the site of lesion. Site of lesion in chorea is caudate nucleus. Site of lesion in balismus is subthalamic nucleus. Subthalamic nucleus. Site of lesion in dystonia is putamen. Site of lesion in atitosis is globus pallidus. Globus pallidus. And what is the site of lesion in Gerstmann syndrome? Can you tell me? Is it dominant parietal lobe or non-dominant parietal lobe? So in Gerstmann syndrome, you get acalculia, agraphia, finger anomia, and right-left confusion. Is it dominant or non-dominant parietal lobe? Answer, dominant parietal lobe. Dominant parietal lobe. Okay. Now, coming to apraxia. Apraxia is due to lesion in dominant hemisphere or non-dominant hemisphere. Answer is dominant hemisphere. So if the MCQ is apraxia is seen in lesion of which hemisphere, answer is dominant hemisphere. But if MCQ is constructional apraxia is seen in which hemisphere lesion, or dressing apraxia is seen in which hemisphere lesion, this is exception. This is non-dominant hemisphere lesion. Non-dominant hemisphere. This is exception. Okay, exception. Right. And hemi-neglect is seen in which parietal lobe? Is it dominant parietal lobe or non-dominant parietal lobe? Can you tell me? It is also non-dominant parietal or the right parietal lobe. Non-dominant or the right parietal lobe. So dominant means left. Non-dominant means right. Okay. Broca's aphasia is lesion in it is due to lesion in inferior frontal gyrus. Inferior frontal gyrus. Which hemisphere? Dominant or non-dominant? Dominant or non-dominant? Dominant. Okay, that is Broca's. What is Wernicke's aphasia? Superior temporal gyrus lesion. Superior temporal gyrus lesion. Which hemisphere? Again, dominant. All aphasias occur in dominant hemisphere lesions. Okay. Conduction aphasia. There are two sites of lesion in conduction aphasia. One site of lesion is arcuate fasciculus. One site of lesion is arcuate fasciculus. There is one more site of lesion in conduction aphasia. It is the area near auditory cortex. Area near the auditory cortex. Okay. Next, anomic aphasia. Anomic aphasia, site of lesion, angular gyrus. Angular gyrus. Okay, right. Again, important table. Let's go to the next table. Working memory, site of lesion. Can you tell me what is the site of lesion of working memory? Working memory, site of lesion is frontal lobe. Episodic memory, site of lesion is medial temporal lobe. Medial temporal lobe. Can you tell me which circuit is important? A potential question which can be asked from physiology. Which is the circuit that is responsible for episodic memory? What is the name of the circuit? It is Pappas circuit. It is Pappas circuit. Okay, Pappas circuit. Semantic memory, which lobe of the brain is important for semantic memory? lateral temporal lobe, lateral temporal lobe. And fasciculation, what is the site of lesion? Is it anterior horn cell or the muscle neuromuscular junction? What is the site of lesion of fasciculations? It is AHC, that is anterior horn cell. Anterior horn cell. Essential tremor का site of lesion क्या है? Essential tremor site of lesion. One is, two site of lesion is there. One is inferior olivary nucleus. Inferior olivary nucleus. Second site of lesion, cerebellum. Cerebellum. Okay, right. Then next is, there are two types of, rigidity in severe neurological diseases. One is decorticate rigidity. Next is decerebrate rigidity. So what is decorticate rigidity? Site of lesion is above red nucleus. So above red nucleus, when there is a damage, you get decorticate rigidity. Above red nucleus, you get decorticate rigidity. So decorticate is abnormal flexion or abnormal extension. Can you tell me? Decorticate rigidity means abnormal flexion or abnormal extension. Can you tell me? Waiting for your comments in the chat box. Yeah, it is abnormal flexion. So there is abnormal flexion of the upper extremities. Lower extremities, there will be extension. Abnormal flexion in upper limbs, that is upper extremities, and there is extension of lower extremities. Extension in lower extremities. In decerebrate rigidity, the lesion is between the red nucleus and vestibular nucleus. Lesion is between red nucleus and vestibular nucleus. This is abnormal flexion or abnormal extension. This is abnormal extension of upper limb, abnormal extension in upper extremities, and again another abnormal extension in lower extremities. So there is abnormal extension in both upper and lower extremities. Spasticity is seen in site of lesion, pyramidal tract. Pyramidal tract. What about rigidity? Rigidity is extrapyramidal tract. Rigidity is extrapyramidal tract. Paratonia. So remember, spasticity and rigidity and paratonia all are types of hypertonia. Okay, so paratonia is a rare type. This happens because of frontal lobe lesions. Frontal lobe lesions. So this is important. Site of lesion, again, high-yield tables. Okay, right. Okay. Somebody is asking, Namrata, how to take the MIQ test series on DocTutorials. This is available in the DocTutorials app, Dr. Namrata. Okay. Now, coming to diseases and investigation of choice in neurology. So multiple sclerosis, investigation of choice is MRI brain and spinal cord. Is it with contrast or without contrast? It is with the contrast. What is the investigation of choice for Guillain-Barré syndrome? I'll give you two options. You have to answer. Is it NCS, that is nerve conduction study, or is it CSF study to look for albuminocytological dissociation? Can you tell me what is the investigation? Nerve conduction study or CSF? Answer is nerve conduction study. CSF for albuminocytological dissociation can be done, but remember that is not the investigation of choice. Investigation of choice is nerve conduction study. Okay. Myasthenia gravis, what is the investigation of choice? Is this acetylcholine receptor antibody? So if they are asking what is the investigation of choice, then it is acetylcholine receptor antibody. If they are asking what is the most specific antibody for myasthenia, answer is acetylcholine receptor antibody. If they are asking what is the most sensitive test for myasthenia, answer is single fiber EMG. Next, myotonic dystrophy and Duchenne muscular dystrophy. In both of them, remember, genetic testing is the investigation of choice. In myotonic dystrophy, genetic testing is investigation of choice. In Duchenne muscular dystrophy, again, genetic testing is investigation of choice. Okay, right. Next is acute ischemic stroke. What is the investigation of choice? You go for CT brain. You can go for MRI also. So if the question is, what is the investigation of choice for acute ischemic stroke? Many times CT is preferred over MRI because CT takes less time. So actually you can go for CT brain plus CT angio of the brain and neck vessels, of the brain and neck blood vessels. This is the investigation of choice. But if they are asking if they are simply asking investigation of choice for stroke, this is the answer. Why you are writing like this? CT brain is to rule out the bleed or stroke mimic. Why you are doing CT angio? Can anybody tell me why you are using CT angio? Okay. Somebody is asking what is DMD? DMD, Duchenne muscular dystrophy. Okay. So CT angio, you are looking for large vessel occlusion. So you are doing CT angio to see if there is occlusion of any large blood vessels. Because if there is occlusion of large blood vessel, you can go for which treatment modality? Can you tell me? Which treatment modality you can go for? Mechanical thrombectomy, also known as endovascular thrombectomy. So if there is a clot in a large blood vessel, you can go for this treatment modality. But if they are asking what is the most sensitive investigation for acute ischemic stroke, then the answer is MRI diffusion weighted image. If they are asking what is the most sensitive investigation for detecting an acute ischemic stroke, then the answer is MRI diffusion weighted imaging, DWI. Subarachnoid hemorrhage, the investigation of choice is non-contrast CT brain. Intracerebral hemorrhage, non-contrast CT brain. But remember, if they are giving you a clinical scenario of a patient with suspected SAH and they are doing a CT scan which is showing a bleed in the subarachnoid space, and they are asking you what is the next test. So if you have confirmed SAH by CT scan, what is the next step? You have to go for CT angio or MR angio or DSA, digital subtraction angiography. So why you want to go for CT angio? Because once you have confirmed it is subarachnoid hemorrhage, you need to do either a CT angio or MR angio or a digital subtraction angiography to look for what? Yes, to look for aneurysm. To look for aneurysm. Right? Good. What is the investigation of choice for cerebral venous thrombosis? It is MRI brain plus MR venogram. What is the investigation of choice for meningitis? Is it CT scan, MRI scan? What do you think? Meningitis ka investigation of choice kya hai? It is not MRI or CT, it is CSF, that is lumbar puncture. So you will do lumbar puncture and analysis of CSF, that is the investigation of choice in meningitis. What about atypical Parkinsonian syndrome? So if it is a typical Parkinsonian disease or a idiopathic Parkinson disease, it is clinical diagnosis. Scan is normal. But atypical Parkinsonian syndromes, you will go for MRI brain. MRI brain. Huntington disease, what is investigation of choice? It is genetic testing. Genetic testing is investigation of choice. You will look for CAG repeats. How many repeats are there that you will look for? Okay. Right. So that is also clear. Okay. Right. So see, whatever I'm giving you as one-liners, I'm giving you this because in your exam, you will get some clinical scenarios and you have to write it. So this PDF, you have to go through it a couple of times because all the high yield content is written there. It will help you for quick revision. You can just go through this and you can quickly go through this. Okay, right. So Rituraj, it's good that you are finding it useful. Okay, next, if you get some clinical scenario of dementia in the exam, Okay, if there is some sort of episodic memory loss, what is the diagnosis? Alzheimer's disease, AD, Alzheimer's disease, episodic memory loss. If you get magnetic gait, urinary incontinence, dementia, normal pressure, hydrocephalus, rapidly progressive dementia, that is memory loss with myoclonus. You think of prion disease, most commonly Creutzfeldt-Jakob disease. If you get fluctuating memory loss, let me see who can answer. If the memory loss is keeping on getting fluctuated, what is the answer? Fluctuating memory loss. It is seen in dementia with Lewy bodies, DLB. Dementia with Lewy bodies. If patient has memory loss and history of recurrent head trauma, what is the diagnosis? Recurrent head trauma happens in boxers. So what is this diagnosis? It is called dementia pugilistica. This happens in boxers who receive recurrent punches over the head. Dementia pugilistica. And what is the new name of dementia pugilistica? It is also known as the new name chronic traumatic encephalopathy. Chronic traumatic encephalopathy. Chronic traumatic encephalopathy. Okay. So if there is metal exposure and patient is having dementia. So what are the metal exposures that can produce dementia? Lead exposure can produce dementia. Mercury exposure can produce dementia. If patient has dermatitis with dementia and also maybe diarrhea, what do you think? Pellagra. So if the combination is diarrhea, dermatitis and dementia combination, it is pellagra. If patient has history of memory loss and confabulation, especially if it is an alcoholic, what condition you will think of? Central pontine, you'll think of Korsakoff syndrome. Korsakoff syndrome. Korsakoff syndrome. If patient has memory loss with anemia and features of either myelopathy or neuropathy, what is the vitamin deficiency that can produce? Vitamin B12 deficiency. Vitamin B12 deficiency. Okay, vitamin B12 deficiency. If patient has chorea with psychiatric manifestations, think of Huntington's disease. Huntington's disease. So we have covered the high yield tables in neurology. Next, we are moving on to some high yield tables from cardiology. Can you give me a thumbs up if you have understood it so far? Can you give me a thumbs up if you have understood? Okay, give me a thumbs up if you have understood. Okay. Right. Now, coming to the various abnormalities of the pulse. Okay, we'll discuss some important high yield tables from cardiology. So, pulsus parvus et tardus, which is a low volume pulse, which is a late peaking pulse. Parvus means low volume, tardus means late peaking pulse. What is the answer? Aortic stenosis. Aortic stenosis. Pulsus bisferiens. What are the conditions? Aortic regurgitation, combined aortic regurgitation plus aortic stenosis. Next, and hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. Next, dicrotic pulse seen in dilated cardiomyopathy, cardiogenic shock, and hypovolemic shock. Okay, right. What about Corrigan's pulse? Corrigan's pulse, also called high volume pulse, high volume collapsing pulse, seen in aortic regurgitation. So remember, aortic regurgitation can have Bispherians pulse, aortic regurgitation can have Corrigan's pulse. Okay, right. Next is pulses paradoxes. What are the conditions? Cardiac tamponade. Most important condition is cardiac tamponade. But what are the other conditions that can produce the uh, pulses paradoxes? Can you tell me? What are the other conditions? Constrictive pericarditis can produce. Superior vena cava obstruction can produce. Acute exacerbation of asthma. Acute exacerbation of chronic obstructive pulmonary disease. Hemorrhagic shock, tension, pneumothorax, all can produce pulses paradoxes. Pulses alternance seen in acute LV dysfunction. Radiofemoral delay seen in coarctation of aorta. Coarctation of aorta. Radial delay seen in Takayasu arthritis. Takayasu arthritis. Okay, but remember, Takayasu arthritis sometimes can also produce radiofemoral delay. Commonly, radial delay Takayasu arthritis produces. Pulse apex deficit seen in atrial fibrillation and VPC. Atrial fibrillation and VPC. VPC is ventricular premature contraction. Okay, right. So very important table on abnormalities of the pulse. Okay, done. Next, they will ask you some scenario of hypertension and the preferred drug. If the MCQ is patient has isolated systolic hypertension, so diastolic BP is normal, only systolic BP is high. What is the preferred antihypertensive agent? Answer is calcium channel blocker. Which calcium channel blocker? Dihydropyridine or non-dihydropyridine? Dihydropyridine calcium channel blocker. If patient is a diabetic patient, the preferred antihypertensive agent is ACE inhibitor or angiotensin receptor blocker. You can use either of this. Okay, what is the advantage? These drugs will prevent proteinuria. So if patient with diabetes develops kidney disease, it will prevent proteinuria. Resistant hypertension, what is the drug of choice? Resistant hypertension, drug of choice is spironolactone. And definition of resistant hypertension is a previous FMGE question. So resistant hypertension means patient BP not controlled despite being on 3 antihypertensive agent and 1 agent is a diuretic. That is called resistant hypertension. What is the preferred drug for hypertension in pregnancy? Labetalol. You can also use other drugs like alpha-methyl dopa. Drug of choice for hypertensive encephalopathy. So there are 3 drugs which are preferred for hypertensive encephalopathy. You can go for intravenous labetalol, nitroprusside, and IV nicardipine. These are preferred drugs. If patient has high blood pressure and is having MI or left ventricular failure. So if patient is having MI or left ventricular failure and the BP is very high BP, that is more than 220, 120 or more than 200, 120. So it is hypertensive emergency. So if hypertensive emergency, which is a hypertensive encephalopathy, you can give labetalol, nitroprusside or nicardipine. If there is a hypertensive emergency due to a myocardial infarction or a left ventricular failure, here you will give which drug? You can give nitroglycerin. Nitroglycerin. Yes. And if patient is having, so somebody is asking pregnancy. I said pregnancy labetalol you can give. Oral labetalol can be given. If it is a crisis, you can give for IV labetalol. Okay. Adrenergic crisis, you can go for phentolamine. So where is adrenergic crisis seen? It is seen in pheochromocytoma. Pheochromocytoma, phentolamine. Okay, right. And next, important table on JVP abnormalities and associated conditions. Absent A wave, which condition? Atrial fibrillation. There is no effective atrial contraction. Giant A wave seen in right ventricular hypertrophy. What is the common cause of right ventricular hypertrophy? Pulmonary hypertension. Cannon A wave is seen in which condition? One is complete heart block and second condition, junctional rhythm. Complete heart block and junctional rhythm. Prominent X descent seen in which condition? Cardiac tamponade. Seen in cardiac tamponade. Okay. Absent X descent seen in which condition? Tricuspid regurgitation. Tricuspid regurgitation. Absent X descent. Then absent V wave seen in hypovolemia. Absent V wave seen in hypovolemia. Prominent V wave seen in hypervolemia. Increased volume. Giant V wave seen in tricuspid regurgitation. Prominent Y descent seen in constrictive pericarditis. Constrictive pericarditis. Constrictive pericarditis. Absent Y descent seen in cardiac tamponade. Cardiac tamponade. Okay. So who's going to tell me what condition you will get the Kussmaul sign? What is Kussmaul sign? So normally during inspiration, there is a fall in the JVP. If there is an increase in the JVP during inspiration, it is called Kussmaul sign. So can you tell me what are the causes of Kussmaul sign? What are the causes of Kussmaul sign? Causes of Kussmaul sign. Waiting for your answers in the comment section. Causes of Kussmaul sign. Okay. Okay. Right. One is constrictive pericarditis. Then restrictive cardiomyopathy. Restrictive cardiomyopathy. Right ventricular myocardial infarction. Right ventricular myocardial infarction. They are common conditions with Kussmaul sign. Okay, right. Also pulmonary embolism. Pulmonary embolism. Pulmonary embolism. Okay, right. Next is hepatojugular reflex. So which condition you get positive hepatojugular reflex? When you apply pressure over the right upper quadrant and you get a sustained elevation in the JVP, can you tell me which condition you get a positive hepatojugular reflex? Impending right heart failure. Impending right heart failure. Right heart failure. So this is an important summary table of JVP. Important summary table of JVP. Okay, impending means there is no heart failure now, but it is going to develop heart failure. Okay. Now, sometimes in FMGE exam, they can give you question on murmurs. So what is this murmur? The first one, this murmur is coming from S1 to S2. So through the entire duration of systole, beginning from S1 up to S2, same intensity, there is a murmur. What is this murmur called? It is a pan-systolic murmur. So which condition you get this PSM or pan-systolic murmur? Chronic mitral regurgitation. Chronic mitral regurgitation. Okay. And also chronic tricuspid regurgitation and also ventricular septal defect. So chronic mitral regurgitation and tricuspid regurgitation and also ventricular septal defect. What is the next murmur? So the second and third murmur, you look, both of them, they are having a crescent shape, crescento-decrescento shape. Both of them are having a crescento-decrescento shape. And both of them are mid-systolic murmurs. They are systolic murmurs, but not happening immediately after S1. There is only after a gap that this murmur happens. The first murmur is ending before the second heart sound. This is the aortic stenosis ka crescento-decrescento murmur, also called diamond-shaped murmur. The third one is the murmur of pulmonary stenosis. So both aortic stenosis and pulmonary stenosis will have mid-systolic murmur, also called ejection systolic murmur. But how will you differentiate? In the second condition, that is pulmonary stenosis, the murmur will extend beyond A2. If it extends beyond A2, then it is pulmonary stenosis. What about the next murmur? It is not systolic murmur, it is diastolic murmur. So it is a decrescento murmur. It starts in diastole and the intensity is decreasing. So it is called decrescento murmur. It is seen in aortic regurgitation and pulmonary regurgitation. This is early diastolic murmur. So this is mid-systolic murmur. This is also mid-systolic murmur. This is early diastolic murmur. What about this murmur? Again, diastolic murmur. This is a mid-diastolic murmur. This is mid-diastolic murmur. Mid-diastolic murmur of mitral stenosis. Mitral stenosis. Okay, mitral stenosis. So what is the next murmur? You can see this murmur starting in systole. It is having a peak at the second heart sound. This is first heart sound. This is second heart sound. And the murmur comes down like this. Can you tell me what is this murmur, which is starting in systole? Ajit, Anirudh, Sean, can you tell me what is this murmur? What is the name of this murmur? Starts in systole, peaks in second heart sound, then extends into the diastole. It's called continuous murmur. This is called a continuous murmur. And continuous murmur is seen in patent ductus arteriosus. So in patent ductus arteriosus, you get machinery murmur. You get machinery murmur. Get machinery murmur. Okay, machinery murmur. Then coming to next. So we will see the important tachyarrhythmias and diagnosis. We will see some important tachyarrhythmias and their diagnosis. So if you look at the ECG and diagnose, okay, I'm giving you the high yield points about each tachyarrhythmia. Okay, let me see who's able to answer all of them correctly. Okay, so I'll be watching out for the comment section. I want to see how many of you get all of them correct. First, you tell me if you get a regular narrow complex tachyarrhythmia where the P waves are present and the P waves are normal in morphology, what is the diagnosis? Regular narrow complex tachyarrhythmia. What are the regular narrow complex tachyarrhythmias? Number one, yes, sinus tachycardia, paroxysmal supraventricular tachycardia, focal atrial tachycardia, and atrial flutter. So what is the diagnosis? Very good. You're all answering well. It is sinus tachycardia. Sinus tachycardia. Next question. If you get a regular narrow complex tachycardia, P waves are present, but the P waves are having abnormal morphology. Okay, but all P waves are looking the same. What is the answer? Regular narrow complex. Regular narrow complex. All P waves are looking the same. What is the answer? All P waves are looking the same. No, somebody is asking, it is PSVT. Somebody is answering, Ayushi is answering, Ajit is answering PSVT. But remember, in PSVT, the P waves will be absent. But here, the P waves are present. So there is a P wave, but they are abnormal in morphology. This is called FAT or focal atrial tachycardia. FAT or focal atrial tachycardia. FAT or focal atrial tachycardia. Okay, next question. You get regular narrow complex tachyarrhythmia and the atrial rate is much higher than the ventricular rate. So atrial rate is around 300, but ventricular rate may be 150 or 75 or 100, 150 or 100 or 75. What do you think? What is this tachyarrhythmia with sawtooth P wave? This is called atrial flutter. This is called atrial flutter. Atrial flutter. If you get regular narrow complex, now you tell me this, I think many of you can answer. Regular narrow complex tachyarrhythmia with absent P wave. What is the diagnosis? This is paroxysmal supraventricular tachycardia. Correct. Okay. Now, if you get irregular narrow complex tachyarrhythmia, what are the two irregular narrow complex tachyarrhythmia? multifocal atrial tachycardia and atrial fibrillation. If you get irregular narrow complex with P waves are present, but varying morphology P waves. So remember, in atrial fibrillation, P waves are absent. So this varying morphology P wave, this will be MAT or multifocal atrial tachycardia. So in multifocal atrial tachycardia, there are multiple foci of arrhythmia. Because of that, these P waves are present, but every P wave, they'll be looking different. All of them do not have same morphology. In focal atrial tachycardia and multifocal atrial tachycardia, both you get abnormal morphology P wave. But focal atrial tachycardia, all the P waves are looking the same. All are having abnormal morphology, but they look the same. In multifocal, they'll be different. Irregular narrow complex with absent P waves. What is the answer? Atrial fibrillation. Atrial fibrillation. Okay. Regular wide complex tachyarrhythmia, that is monomorphic ventricular tachycardia. Irregular wide complex, it is polymorphic ventricular tachycardia. Irregular wide complex, it is polymorphic ventricular tachycardia. This is a summary table of all the tachyarrhythmias. So let us just practice. Can you tell me? This will be a wide complex tachyarrhythmia, which is regular. So wide complex regular tachyarrhythmia, what is the answer? It is, what is the diagnosis? This is monomorphic ventricular tachycardia. This is a monomorphic ventricular tachycardia. Yes, because the QRS duration is wide. QRS, so it's wide complex. The rhythm is regular, so it is wide complex regular. And the morphology is looking the same. It's monomorphic VT. What about this one? Again, wide complex, but you can see that they are not regular. And also there is varying shape. What is this? It is called polymorphic VT. The QRS complexes are having different shape. So this is polymorphic VT. Yes, right. Now this one. What about this one? This one is also a type of polymorphic VT, but what is the difference? You can see that there is a, if you look at the ECG, you can see that there is an oscillating pattern. So what is this oscillating pattern where you get a twisting of axis? A type of polymorphic VT where you have got an oscillatory change in the amplitude of QRS complexes. Very good. It is torsades de Pontus. Torsades de Pontus. Correct. Answer is correct. Okay, right. Now, what about this arrhythmia? You get a narrow complex irregular. Okay, it is a irregular narrow complex tachyarrhythmia with absent P waves. You are not seeing some P waves, but you are seeing some fibrillary waves. Definite P wave morphology is absent, but you are having fibrillary waves. The answer is atrial fibrillation. AF, atrial fibrillation. What about this one? You can see ventricular rate is normal. Ventricular rate is only 75 per minute. Okay. But if you look at the atrial rate, you can see between two consecutive P waves, there is one large square. So the atrial rate is 300. So atrial rate is 300. Ventricular rate is only 75. Okay. Right. And look at the P wave morphology. It is having a sawtooth shape. So this is sawtooth morphology. So always remember, in case of atrial flutter, almost always you will have AV block. So if you look here, this one is an atrial flutter with a 4:1 AV block. What is atrial flutter with 4:1 AV block? Because you are seeing one QRS complex only after 4 P waves. 1, 2, 3, 4. There are 4 P waves, and after that you are having one QRS. So this is atrial flutter with 4:1 AV block. Okay. What is the most common type of AV block associated with atrial flutter? Is it 4:1, 3:1, 2:1? What is the most common type of AV block associated with atrial flutter? Answer is 2:1 AV block. Okay, right, good. And what about this ECG? Whenever you are having an ECG like this, if you want to make a diagnosis about the arrhythmia, first look at lead 2, which is the rhythm strip. You look at rhythm strip. you are seeing that this is a regular narrow complex tachyarrhythmia. So what is narrow complex and wide complex? Narrow complex means the QRS duration is less than 3 small squares. The wide complex means the QRS duration more than 3 small squares. So tell me, when there is a regular narrow complex tachyarrhythmia, and in the comment section, can you answer Ajit, Anirudh, Ayushi, Neetu, is there any P wave? Are you able to see a P wave? Answer is no. You're not able to see a P wave. So what is the diagnosis? PSVT, paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia is the diagnosis. Now, let's have a look at an MCQ. A patient presented to the emergency department in a drowsy state. He was in hypotension and the ECG showed a narrow complex tachycardia. What is the next best step in the management? Can you tell me what is the answer? What is the next best step in management? Can you answer? So whenever you get a narrow complex tachyarrhythmia or a wide complex tachyarrhythmia, whatever it is, if the patient is having features of hypotension, if patient is having features of heart failure, so in what all conditions will you go for DC shock? Any tachyarrhythmia, okay, any tachyarrhythmia having a pulse and patient having either hypotension, please note it down, when to go for DC cardioversion. If patient is having either hypotension or altered sensorium, hypotension, altered sensorium, or signs of shock, or features of heart failure, or patient is having ischemic chest pain. So if any of them is present, then you have to go for DC shock. Here patient is in hypotension. So what is the treatment? You have to go for synchronized DC cardioversion. Synchronized DC cardioversion is the treatment that you have to offer. Okay, synchronized DC cardioversion. So remember, synchronized DC cardioversion is done when there is a shock. Okay, when the patient is in shock like hypotension, you have to offer a DC shock has to be given. Suppose if the question, the patient, it was not given that the patient is having hypotension. Suppose blood pressure was normal, then what is the treatment? Normal blood pressure, patient having narrow complex tachyarrhythmia, then the answer is IV adenosine 6 mg bolus or even a carotid massage. Both of them can be given. First, you will give a carotid sinus massage. So if it is a stable narrow complex tachyarrhythmia, the first treatment that you will offer will be a carotid sinus massage. You will give a massage over the carotid artery. So where is the massage given? Between the angle of mandible and the upper border of thyroid cartilage. You will give the massage for about 3 to 10 seconds. So you will give the massage, and this massage sometimes can revert the arrhythmia. If it is not responding with the massage, the next step is IV adenosine. Understand? Right. So that is clear. So if the ECG is showing wide complex, suppose wide complex tachyarrhythmia with hypotension, then so Jay is asking, sir, in narrow complex carotid massage is given. Yes, regular narrow complex tachyarrhythmia, you will give carotid massage, carotid sinus massage. Okay, right. Regular, you can give carotid sinus massage. That is correct. If it is not responding, you can give the diltiazem. If it is not responding with adenosine, then you can give verapamil or diltiazem. If it is not responding with adenosine, then you can give verapamil or diltiazem. Okay. Cardioversion, which means the DC shock that you are giving. Okay, right. So that is clear. Okay. Any other doubts? Any other doubts you have got? What about wide complex? If it is wide complex and the patient is having a, if the patient is not in hypotension, what is the drug you will give? Suppose ventricular tachycardia patient coming to you with palpitations. Okay, ventricular tachycardia patient coming to you with palpitations. What drug? So in the question here, drowsy is also mentioned. Okay. Yeah. Ventricular tachycardia, you can go for amiodarone. Amiodarone can be given. Amiodarone is the drug that can be given. Amiodarone infusion can be given. So you will give a bolus dose of 150 milligram followed by 1 mg per minute for first 6 hours, followed by 0.5 mg per minute for the next 18 hours. Okay, amiodarone can be given. If there is not reverting with amiodarone, go for DC shock. But if ventricular tachycardia, again, with any of these features, directly go for DC shock without amiodarone. Okay, right. Next MCQ, which is not true about high quality CPR. Chest compressions at 100 to 120 per minute. Chest compressions 3 to 4 centimeter depth. Allowed complete chest recoil and compression ventilation ratio is 30:2. What do you think is the answer for this? What do you think is the answer for this? So the first statement is correct. Chest compression, it is at 100 to 120 per minute. Chest compression at 3 to 4 centimeter depth, it's wrong. You have to give 5 centimeter depth compression. That's a wrong statement. Allow complete chest recoil is correct. Compression ventilation ratio 30:2 is also correct. So this one is the answer. Okay, chest compressions at 3 to 4 centimeter depth. Okay, right. Okay, so a few other bradyarrhythmias which are commonly asked. What about the first bradyarrhythmia? You can see that there is a prolongation of PR interval. And the prolongation of PR interval is constant. There is a constant prolongation of the PR interval. So what is the diagnosis? Constant prolongation of PR interval. So this would be a first degree AV block. So somebody has answered second degree. Sean, it's not second degree. Because second degree AV block means there should be a non-conducted P wave. If you look at this, Sean, you can see that all the P waves are followed by QRS. There is no non-conducted P wave, Sean. So definitely this is a first degree AV block with a constant prolongation of the PR interval. What about the second ECG, Sean? Try the second one. If you look at the PR interval, definitely abnormal, and you're having a constant prolongation of the PR interval. And you can see that after a prolonged PR interval, and now see, Sean, you can see one P wave is not getting conducted. You can see a P wave which is not getting conducted. So that it means non-conducted P wave means there is a P which is not followed by QRS. Again, you can see there is a prolongation of PR interval. Okay. So what do you think is the diagnosis for this? What do you think is the diagnosis? This is a second degree AV block, Mobitz type 1. And what is the phenomenon known as? The phenomenon is known as Wenckebach phenomenon. Wenckebach phenomenon. Okay. And what about the next ECG? If you look at the PR interval, you can see that all the PR intervals are normal, but you can see that there is suddenly a non-conducted P wave. So when you get a non-conducted P wave, you're quite sure that this is a second degree AV block, but here you're not getting Wenckebach phenomenon. So what is the diagnosis here? This is second degree AV block, Mobitz type 2. Okay, Mobitz type 2. Okay, right. And what about the third ECG? Third ECG, please look. Can you tell me what is the diagnosis? Neetu, Ajit, Rupali, Blessy, can you please answer? What do you think is the diagnosis? Very good, excellent. You're answering very well. I'm very happy that you're all well prepared. So this is an AV dissociation. So what is AV dissociation? In AV dissociation, let us first have a look at the P wave. So can you first spot the P waves? You have to look carefully. Then only you'll be able to identify all the P waves. Remember, this is a P wave. Let me spot the P waves for you. This is a P wave. Remember, this is also a P wave. Can you see the notch? This is a P wave. 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 Right? And let us now spot the QRS complex. This is a QRS, QRS, QRS. Now I want you to tell me the answers for the following points that I'm asking you. What about the PP interval? Is it constant or is it varying? Can you answer? Is it a constant PP interval or varying PP interval? What do you think? What do you think? The PP interval is constant. Okay. What about the RR interval? What about the RR interval? This also would be constant. Now answer me, what happens to the PR interval? Is it constant or is it varying? Is it constant or varying? This is a varying one. So this condition is characterized by AV dissociation, atrioventricular dissociation. This is seen in third degree AV block, which is also called complete heart block. Third degree AV block, also called complete heart block. Okay, right. So we have discussed all the arrhythmias. Okay. So I hope so far the revision is going good. Yes. Please let me know in the comment section. Are you able to follow? Okay, I'm going a bit fast, I know, but I'm trying to be crisp here so that will help you for revision. Can you please let me know if you are following it and everything is going good? Okay, right. So let's have a look at this ECG. Can you tell me what is happening when you look at the ECG? Okay, can you tell me what is happening? Okay, you please look at the ECG and tell me what is happening. Okay, you can see that the finding is ST elevation. So can you tell me which are the leads which are showing ST elevation? Can you tell me which are the leads? You're correct, it is ST elevation. Lead V1, lead V2, lead V3, lead V4. So definitely anterior wall is there. But can you tell me, is there any other wall that is showing ST elevation? Yeah, Sean, you said V1 to V4. And Blessy is saying ST elevation. Rupali says anterior wall MI. But let me ask you, other than V1 to V4, any other leads? Please look at 1 and AVL. I'm saying that there is ST elevation in 1 AVL also, correct or not? There is 1 AVL ST elevation also. And you are seeing a reciprocal ST depression in leads 2, 3 AVF. So now tell me, is it anterior wall MI or anterolateral wall ST elevation myocardial infarction? You tell me which is more correct. Yes, it is anterolateral wall ST elevation MI. This would be an anterolateral wall. Okay, so what are the lateral leads? You've got lead 1 AVL and V5, V6. V5, V6 may not significant ST elevation, but 1 AVL definitely is. So I can say it is anterolateral wall ST elevation MI. What about this ECG? What about this ECG? Okay, which leads are showing ST segment elevation? Can you tell me? Which leads are showing ST segment elevation? So you can see there is ST elevation in lead 2, lead 3, and lead AVF. And there is some reciprocal ST depression also. But when you get ST elevation in lead 2, 3 AVF, what is the diagnosis? What is the diagnosis? It is inferior wall ST elevation myocardial infarction. Inferior wall ST elevation myocardial infarction. Okay, now that is correct, inferior wall. But let me ask you one additional point for students who are very bright and who have listened to the classes very carefully, you will be able to answer. If in an inferior wall ST elevation, if you get ST depression in V2 and V3 leads, what else should you suspect? In an inferior wall MI, if you get an ST depression in V2 and V3, what else should you suspect? It is inferior wall MI plus what? There is additional involvement of what? Additional involvement of what? This is posterior wall myocardial infarction. Okay. So when you get a combined inferior plus posterior, you get 2, 3 AVF ST elevation and ST depression in V2 and V3. That's a depression in the, but that's okay. Even if you do not know that, it is fine. I'm just testing whether you know it or not. That's the only thing. For you, I think in exams, they'll only ask this much inferior wall ST elevation MI. I just asked it as an additional point. Okay. Now tell me in ST elevation MI, what is the best treatment for ST elevation MI? What is the best treatment for ST elevation MI? Suppose in options, there is both PCI and thrombolysis. What will you choose? In options, both are there. PCI is there and also fibrinolysis or thrombolysis. Yes, very good. Always remember PCI is better than fibrinolysis. Always PCI is better than fibrinolysis unless you are not having a option for doing a percutaneous coronary intervention. Okay, right. That is correct. Now, tell me what is this ECG finding? You look at the ECG and what is the finding? Please look at lead 2. What is the ECG finding? Okay. So this patient presented with breathlessness and hemodynamic compromise, hypotension. Breathlessness and hypotension. Very good, Rituraj. So Rituraj has rightly identified that there is low voltage complexes. So one finding by Rituraj is correct. All the complexes are looking small. So there is low voltage complex. Rituraj, if you just look again carefully once more, you please look at the individual complexes. Can you see that you have alternate high volume and low volume? Yes or no? Some complexes are high volume, relatively larger amplitude than smaller amplitude. So there is alternating amplitude of the complexes, not volume actually. It is the height or the amplitude. So what is this called as? When you get alternating, high and low amplitude, this is called electrical alternance. So electrical alternance is a feature of cardiac tamponade. Okay, electrical alternance is a feature of cardiac tamponade. It's a feature of cardiac tamponade. Okay, it's a feature of cardiac tamponade. Okay, done. Okay, cardiac tamponade. What is the characteristic triad of cardiac tamponade? Can you tell me? Always remember Beck's triad. The characteristic triad is Beck's triad. Is very favorite for FMGE exams. They commonly ask questions about Beck's triad. Okay, now what about this ECG? What is the ECG finding here? What is the ECG finding here? So you look at the PR interval. You look at the PR interval and you look at the QRS complex. So you are seeing an ECG where there is a short PR interval. Okay, there is a short PR interval and there is some, if you look at the QRS complex, there is some slurred upstroke of the QRS. So there is a delta wave. There is a delta wave, which is a slurred upstroke of the QRS, and there is a wide QRS. And are you seeing any Q wave? There is absent Q wave also. So these are ECG findings of which condition? Absent Q wave. This is all seen in very good, WPW, Sean, Ajit, Atul, Rupali, very good. These are all features of WPW syndrome. Very good, WPW syndrome. Okay, right. That's it. Now, another ECG, can you tell me what is the likely electrolyte abnormality that may be seen in this patient? So you will be given, maybe this patient is a chronic kidney disease patient. And can you tell me what is the electrolyte abnormality that may be seen? You can see that the T waves, you can see tall peaked T waves. You can see tall peaked T waves. And you can see the P waves are also absent. So what is the ECG abnormality? Tall peaked T waves. Very good, Rupali, Pranay. It is hyperkalemia. So in hyperkalemia, you get tall peaked T waves. Important electrolyte abnormality. Okay. And you mainly will see this hyperkalemia tall peak T waves in the precordial leads. Okay. What about this ECG? And what is the electrolyte abnormality associated with this ECG? Again, please look at this carefully. Can you see that immediately after the T wave, there is another wave? What is this? After T wave, you are seeing another wave. What is this? This is called U wave. So which condition you get prominent U wave? Okay. Which condition you get prominent U wave? So Pranay is asking, can you explain WPW once again? Pranay, what happens in WPW or Wolff-Parkinson-White is that it is a pre-excitation syndrome. So the impulse is reaching the ventricle early. So the PR interval will be short. and the Q wave will be absent. The QRS, you will see a slurred upstroke of the QRS. So please look at this. You will see that the QRS complex is having a slurred upstroke, and the total duration of QRS will be wide also. It's called WPW syndrome. Okay, right. So this would be a prominent U wave, which is a feature of hypokalemia. Prominent U wave feature of hypokalemia. Okay, right. Next, what is the ECG finding? Again, you will be given a patient who is having some prolonged immobilization and patient developing sudden onset breathlessness. Sudden onset breathlessness. What is this pattern? You look at this, you can see that in the lead 1, there is a prominent S wave, a very prominent S wave in lead 1. And in the lead 3, you can see a prominent Q wave. And also in lead 3, you can see T inversion. So when you get prominent S wave in lead 1, a prominent Q wave in lead 3, and T inversion in lead 3, this is called a S1 Q3 T3 pattern. S1 Q3 T3 pattern. Okay, right. Okay, right. And that is clear. And this pattern will be seen in pulmonary embolism. Pulmonary embolism. So can I ask you 2 MCQs? If the MCQ is, what is the most specific ECG pattern in pulmonary embolism? Answer is S1 Q3 T3 pattern. If they're asking you what is the most common ECG pattern in pulmonary embolism, what would be the diagnosis? Answer. Most common. Most common, what is the answer? Sinus tachycardia. Ajit, you are absolutely right. So most common ECG finding in pulmonary embolism is sinus tachycardia. Most specific ECG finding is S1 Q3 T3. And what about this one? If you get a Osborne wave, okay, you can see this notched deflection. This is called a J wave or Osborne wave. And can you tell me what condition is associated? Because in the QRS, you are having a small deflection, and this would be the Osborne wave seen in hypothermia. So hypothermia would have Osborne waves. Okay, right. Now next is, you look at 3 gross images. This is commonly asked in FMGE exams. The gross images of the various cardiomyopathies. So I'm giving you 3 cardiomyopathies: dilated, hypertrophic, and restrictive. So images 1, 2, 3. First of all, tell me, which is dilated cardiomyopathy? Is it 1, 2, or 3? You look at the image. You can get this as a pathology question as well. Which is dilated cardiomyopathy? Tell me which is dilated cardiomyopathy. Okay, which is dilated cardiomyopathy? Anyone? Ritik, Hemant, Dev, can you answer? Okay, which is dilated cardiomyopathy? Absolutely right. The first one is the dilated cardiomyopathy, and you can see that the ventricular cavity is quite big, and the wall of the ventricles, they are quite thinned out. You can see thinned out walls of the ventricles with enlarged ventricular cavity. This is a feature of dilated cardiomyopathy. Okay, right. What about the second one? Second one, you get a banana-shaped left ventricular cavity, correct? You get a banana-shaped left ventricular cavity, and you can see there is a hypertrophy involving the septum and the free wall, but the predominant hypertrophy is involving the interventricular septum. Hence, the diagnosis is hypertrophic obstructive cardiomyopathy. What about the third one? In third one, can any one of you tell me what is the most important gross finding of restrictive cardiomyopathy? In restrictive cardiomyopathy, the common example is that of amyloidosis. Can you tell me what is the finding in the gross? See, because the ventricular wall is quite stiff because of deposition of amyloid, the atria has to pump against a stiff ventricle, because of which the atria will get enlarged. So the characteristic feature of restrictive cardiomyopathy is a massive atrial enlargement. Massive atrial enlargement. And this would be a restrictive cardiomyopathy. You can also get a potential MCQ regarding the histopathological finding of each of them. In dilated cardiomyopathy, The histopathological characteristic finding is the ninja star nuclei. In case of hypertrophic obstructive cardiomyopathy, you can have a very haphazardly arranged myocardial fiber, which is called myofiber disarray, a total haphazardly arranged myocardial fibers. And the third one is called, the finding you get is, you will have amorphous, pink amorphous deposits. Okay, pink amorphous deposits in the histopathological examination in the routine H&E stain. Pink amorphous deposits you can see. And then next is another important MCQ, again a previous FMG question. What is the condition that can produce differential clubbing, where you get clubbing involving the lower limbs, but clubbing is absent involving the upper limbs? What is this called? This is called differential clubbing. And what condition would be causing a differential clubbing where you have got clubbing only involving lower extremities? This would be seen in a patent ductus arteriosus with Eisenmenger's syndrome. With Eisenmenger's syndrome. Okay. Yes, with Eisenmenger's syndrome. Okay, right. Now, the next MCQ, very, very important. A 60-year-old diabetic patient presents with symptoms of exertional dyspnea and pedal edema of 1 year duration. Auscultation revealed bilateral crepitations. Echocardiography showed reduced ejection fraction. Which of the following reduces the progression of heart disease in this patient? So it is a diabetic patient and he is having heart failure with reduced ejection fraction. They are asking which drug is reducing the progression of the heart disease. Is it furosemide, hydrochlorothiazide, empagliflozin, or digoxin? Always remember that there are 4 pillars of heart failure treatment. What are the 4 pillars of heart failure treatment? So the first pillar of heart failure treatment, that is heart failure with reduced ejection fraction, it is ARNI. This is the first pillar. So what is ARNI? Angiotensin receptor neprilysin inhibitor, which is your sacubitril valsartan combination. So is ARNI given in the option? No, it is not given in the option. So instead of ARNI, you can even use ACE inhibitors or angiotensin receptor blockers. But if you are asking me, sir, which is the best one? Definitely ARNI is the best. If it is not there, ACE or ARB. Is it there in the option? AC inhibitor is not there. ARB is not there. So what is the next pillar? The next pillar is beta blocker. So the next pillar of heart failure treatment is beta blocker. Which all beta blocker? The MBC beta blocker. That's the mnemonic. So metoprolol, bisoprolol, and carvedilol. The MBC beta blockers, metoprolol, bisoprolol, and carvedilol. Is any of them in the option? That is also not there. The third option is mineralocorticoid receptor antagonist. Which one? Spironolactone. Is it there in the option? No, it is not there in the option. The fourth one is SGLT2 inhibitors. SGLT2 inhibitors. Is there any SGLT2 inhibitor in the option? Yes. Option C, empagliflozin is an SGLT2 inhibitor. So these 4 drugs are the 4 pillars of heart failure treatment. Please remember them. Highly expected question for FMG exam. Answer is option C, empagliflozin. Is it clear? Okay. Okay. Next one, again, a favorite question. Roth spots. Can you tell me which condition is associated with Roth spots? You can see on fundus examination, you can see areas of hemorrhages. And in these areas of hemorrhages, if you look at the center part, it appears pale. So you get hemorrhages with pale centers. So it is Roth spots seen in infective endocarditis. Understood? Yes, that is also done. Okay, right. So we have done with cardiology. Most of the important stuff in cardiology we have summarized. If you are with me, if you are clear regarding this, give me a thumbs up. Okay, so neurology, cardiology, most of the important points for FMG exam we have summarized in the form of tables, a few MCQs we have summarized. Okay, right. So always remember, as I said, before your FMG exam, please go through this PDF multiple times. So many points are there. So many points are there. Okay, Ritik, Dev, okay, good. Right. So all of you are with me. Let us go to the next step. Important table, very important table. We know that vasculitis is a big topic. Okay, so I'm going to summarize vasculitis into one table where all the important vasculitis have been covered, okay, which are important for your exam. First of all, if you get a vasculitis where the age of the patient is more than 50 years, okay, and so remember, when the age is more than 50 years, what is the vasculitis you will think of? Age more than 50 years. So elderly with a vasculitis, always think of which condition? Giant cell arteritis. Ritik, wonderful, wonderful, well answered. Giant cell arteritis. Okay. Okay, right. So you get headache, jaw claudication, and on examination, temporal artery tenderness. So what do you think? All these features are suggestive of giant cell arteritis. Okay, what is the drug of choice? Steroids. What is the monoclonal antibody that can be used? Tocilizumab. Okay, important. Right. Okay, next, if the age of the patient, so giant cell arteritis, what type of vasculitis is it? It is a large vessel vasculitis. What about second scenario? Age 20 to 40 years. Patient is having arm claudication as symptom. So arm claudication means maybe subclavian artery is involved. Examination, the weak or absent pulses. So which vasculitis, you know that it is pulseless disease, and also there is unequal blood pressure. So between the upper limbs, there can be difference of blood pressure. This is Takayasu arteritis. Takayasu arteritis. This is very important, Takayasu arteritis. So what is the most common blood vessel involved in Takayasu arteritis? Subclavian artery. Okay, right. So Takayasu is a large vessel vasculitis. Okay, so remember GCA and Takayasu both are large vessel, but GCA is in females above 50 years. GCA can be seen in males also, but more common in females. Takayasu, again females, but the age group is 20 to 40 years. Okay. Now, if you get a vasculitis of a patient who is having renal failure, but there is no glomerulonephritis, so his urine is not having any RBC cast, and he is having hepatitis B positive. What do you think? What is the likely diagnosis? Yeah, very good. It is polyarteritis nodosa, PAN or polyarteritis nodosa, which is a medium vessel vasculitis. And many cases are having hepatitis B positive. Okay. Why there is no glomerulonephritis? Because PAN is a medium vessel vasculitis. Okay. It is not a small vessel vasculitis, so it does not affect the glomerulus. Okay. Right. That's about polyarteritis nodosa. Also remember, I mentioned in the lecture that what is the other characteristic symptom of polyarteritis nodosa? Testicular pain and tenderness. Testicular pain and tenderness. Which vasculitis will have coronary artery aneurysms? Can you tell me which vasculitis will have coronary artery aneurysms? Kawasaki disease. Kawasaki disease would have coronary artery aneurysms. Now, some of the vasculitis can present with pulmonary renal syndrome, which means they'll be having some sort of cough with hemoptysis and renal involvement in the form of glomerulonephritis. Okay, so if you get a pulmonary renal syndrome with a C-ANCA positive, what is the likely diagnosis? Wegener's granulomatosis. If you get pulmonary renal syndrome, cough, hemoptysis, features of glomerulonephritis like cola-colored urine with P-ANCA positive, you will think of which disease? Microscopic polyangiitis. If you get a pulmonary renal syndrome where ANCA is negative, you will think of Goodpasture syndrome. Okay. If you get the age of the patient of 4 to 7 years, so always vasculitis in children, you should think of Kawasaki and Henoch-Schondlin purpura. So in HSP, the age is 4 to 7 years with palpable purpura, polyarthralgia, and abdominal pain. So the answer is Henoch-Schondlin purpura. What is the other name of Henoch-Schondlin purpura? IgA vasculitis. Okay, right. Okay. Now, if you get oral ulcers, genital ulcers, uveitis, deep vein thrombosis, and brainstem stroke, what is the diagnosis? Behçet's disease. Behçet's disease. What is the skin test for Behçet's disease known as? Anybody? What is the skin test for Behçet's disease known as? Pathergy test. It's called Pathergy test. And there is one other vasculitis I want to discuss with you. Can you tell me which is the vasculitis that can be associated with purpura, arthralgia, glomerulonephritis, and mostly patients will be either positive for hepatitis C or multiple myeloma. So if there is a patient having hepatitis C, okay, patient with hepatitis C or multiple myeloma developing a purpura, arthralgia, and glomerulonephritis, what condition you think of? It is cryoglobulinic vasculitis. Cryoglobulinic vasculitis. Okay, cryoglobulinic vasculitis. Okay, right. Okay, right. Okay. So I think that's it. Okay, so we have discussed some very important table, summary table of the vasculitis. Which is the vasculitis out of this that can produce saddle nose deformity? Which vasculitis can produce saddle nose deformity? Saddle nose deformity can be produced by Wegener's granulomatosis. Wegener's granulomatosis, saddle nose deformity. Okay, right. Then in rheumatology, so this is a very important table from rheumatology, a concise table. Then another point is, in case of rheumatology, important disorder is systemic lupus erythematosus. Can you tell me systemic lupus erythematosus is going to produce what type of alopecia? Is it non-scarring alopecia or scarring alopecia? SLE characteristically produces non-scarring alopecia. But can you tell me which condition can result in scarring alopecia? Can SLE produce scarring alopecia? If yes, when it is associated with which condition? So if in MCQ they are asking SLE produces what alopecia, answer is non-scarring. But there is one condition where SLE may be associated with DLE, which is discoid lupus erythematosus. It can produce a scarring alopecia. Okay, DLE is the most common chronic cutaneous manifestation of SLE, where you get discoid or coin-shaped lesions over your scalp, which can sometimes merge together and form large areas of alopecia with a scar. Okay, right. And another MCQ point you should notice, in your exam, if you get a scenario of a patient having a hand deformity, there are two important possibilities. One is rheumatoid arthritis and the other is systemic lupus erythematosus. But what is the important point of difference? In rheumatoid arthritis, bone erosions will be present. It is an erosive arthritis. Whereas in case of SLE, the bone erosions will be absent. You look at the X-ray, there is so much of bone erosions here, but the X-ray here is not showing much bone erosions. So it is a non-erosive arthritis. Okay, important, right? Another MCQ point is regarding the, the CT appearance of certain interstitial lung diseases. So some of the rheumatological disorders may be associated with ILD, that is interstitial lung disease. Two important interstitial lung diseases that can be associated with ILD are usual interstitial pneumonia and non-specific interstitial pneumonia. Can you tell me if you get in the CT scan a ground glass appearance, a ground glass hazy appearance? Yes, as Sean said, this is likely to be non-specific interstitial pneumonia. And if you get a honeycombing, so in honeycombing, you can see it is not haziness, there is some sort of a destruction of the lung parenchymal architecture. This would be usual interstitial pneumonia. Now, out of the rheumatological disorders, the NSIP is the form is more common with which rheumatological disorder? Systemic sclerosis. With systemic sclerosis. Whereas usual interstitial pneumonia is a feature of which disorder? It is a feature of rheumatoid arthritis. Rheumatoid arthritis. Okay, this is very, very important. So both are interstitial lung disease, But based on CT scan, you'll be able to say, is it NSIP or UIP, which is usual interstitial pneumonia. Okay. And then if you get a clinical scenario of a patient who is having proximal muscle weakness, and there are certain papules like this. These are called Gottran's papules, which are erythematous papules over the knuckles. So if you get this, what is the diagnosis? It is dermatomyositis. 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 Okay, right. Now, the next finding is if you get an X-ray where you have some erosions. So there is a bone erosion, but along with the bone erosion, you can see that there is overhanging bone. So erosions with overhanging bone. Can you tell me what it is? So there is erosion, but areas of erosions will be having overhanging bone. This is called Martel sign. This is a feature of gout. This is a PYQ. Feature of gout. Okay, this is a PYQ. And tell me, what is the investigation of choice for gout? Is it serum uric acid, or is it synovial fluid analysis under polarizing microscopy? Remember, it is synovial fluid analysis under polarizing microscopy, which would show, can you tell me what is the finding? You will get negatively birefringent needle-shaped crystals. Negatively birefringent needle-shaped crystals. Okay. And always remember, what are the drugs that can be given in acute gout? NSAIDs, colchicine, steroids. Can you tell me what is one drug which can be used in chronic gout but is contraindicated in acute gout? Always remember, allopurinol is contraindicated in acute gout. Allopurinol is contraindicated in acute gout. Okay, right, done. Next, another important X-ray finding. You can see this is the X-ray of the knee joint, and you can see there is arrow that is pointing to some sort of a calcification involving the menisci. In the region of menisci, there is calcification. What do you call this? It's called chondrocalcinosis. And this is associated with which condition? Pseudogout. And what is the other name of pseudogout? Calcium pyrophosphate dihydrate deposition disease, also called CPPD disease. Okay. And what is the investigation of choice? Again, synovial fluid analysis under polarizing microscopy. But this would show a weak positive birefringent. The other was negatively birefringent. This would be a positively birefringent rhomboid crystals. Okay, rhomboid crystals. Done. Right. Now, next, if you get a clinical scenario of a patient with chronic cough and hilar lymphadenopathy. So if you get this combination, you first think of either tuberculosis or sarcoidosis. Any patient with chronic cough and hilar lymphadenopathy, two possibilities, TB or sarcoidosis. But if the question mentions there is raised serum angiotensin converting enzyme levels, then what is the diagnosis? Then the diagnosis is it is sarcoidosis. It is sarcoidosis. But if it is mentioning that CB-NAT from the lymph node aspirate, you are doing gene expert, also known as CB-NAT. So if that is positive, it is tuberculosis. So the lymph node aspirate, CB-NAT or gene expert is positive, it is tuberculosis. If serum angiotensin converting enzyme is elevated, it is sarcoidosis. Understood? Right. Now, next is panda sign. So if you do the gallium-67 scan and if you get a panda sign, sometimes lambda sign, this is a feature of which condition? Again, PYQ, it is sarcoidosis. Sarcoidosis. Okay, right. Next, so we have finished the important points about rheumatology. Okay, so we're done with neuro, cardio, and rheumatica important points. Let us now discuss some important points about pulmonology. Okay, about pulmonology. So in pulmonology, if you see, based on the volume time plot that is shown, what is the likely diagnosis? Can you answer? What is the likely diagnosis based on the volume time plot? Based on the volume time plot. So you look at the volume time plot. So you're seeing the normal volume time plot, and this will be the abnormal volume time plot. So you must know how to differentiate the volume time plot of obstructive lung disease and restrictive lung disease. So this image in your workbook, this is a normal volume time plot. Now let us see what is happening in obstructive lung disease. In obstructive lung disease, what is happening is you can see that there is a sloping volume time plot. So the FEV1 and FVC both are reduced, but more significant drop is in FEV1. So if you look at the ratio between FEV1 and FVC, it is very much reduced. Okay, if as per the GOLD guidelines, it is reduced less than 0.7 in obstructive lung disease. So you get a this sort of a volume time plot in obstructive lung disease. But in restrictive lung disease shown in yellow, so there what is happening? You can see there is no problem with the slope of the volume time plot. The only thing that happens is you get a similar volume time plot at a miniature form or a smaller sized. You look at this, the volume time plot, the slope is the same. The only thing is that it is smaller in size. You get a miniature form where the FEV1 and FVC, if you look, the FVC is much more reduced compared to FEV1. So if you look at the ratio, it is normal or increased. Okay, normal or increased. So this is how you will differentiate. Now you tell me, out of the options that are given, what do you think? Is it going to be an obstructive lung disease or restrictive lung disease? Well, this is going to be the volume time plot of a obstructive lung disease. Bronchiectasis is obstructive and idiopathic pulmonary fibrosis is restrictive. Sarcoidosis is restrictive and chest wall deformity is also restrictive. Okay, chest wall deformity is also restrictive. Okay. Next is you have to know about the flow volume loop. Flow volume loop, this is the normal flow volume loop. So this one that is given in your workbook is the normal flow volume loop. Okay, normal flow volume loop. Now if in a flow volume loop, if you take, so this one will be normal and look at this abnormal. I'm marking with red an abnormal flow volume loop. Suppose there is a concavity involving the descending limb of the expiratory part. So this is the expiratory part of the flow volume loop. This is the inspiratory part of the flow volume loop. So if there is a concavity involving the descending limb of the expiratory part of the flow volume loop, what does that mean? Somebody is answering COPD. Well, this concavity of the flow volume loop, it means it is an obstructive lung disease. This can either be a COPD or it can be a asthma. It can be COPD, it can be asthma. How to differentiate? We'll see that very soon. Now, I want all of you to draw along with me a very important flow chart. Okay, so I've given some space in the workbook. That is after this particular flow diagram. You can see in the workbook there is a space. I want all of you to draw along with me. So first of all, you look the FEV1 to FVC ratio. So when you have got a lung disease, FEV1 to FVC ratio you have to look. So there are two possibilities. Number one, this ratio is low, and the second possibility is this ratio is normal to increased. Normal to increased. Normal to increased. So when this ratio is low, which means it is less than 0.7. All of you, please draw along with me. If it is less than 0.7, the answer is this is an obstructive lung disease. Okay, this is an obstructive lung disease. This is an obstructive lung disease. Okay, obstructive lung disease. Now, obstructive lung disease, it can be either a bronchial asthma or COPD or bronchiectasis. So how to differentiate whether it is asthma or COPD? Now you have to see whether there is bronchodilator reversibility. Bronchodilator reversibility. That means you are giving a bronchodilator, and is there a reversibility or not? If the answer is yes, if the answer is yes, then the diagnosis is bronchial asthma. the diagnosis is bronchial asthma. If there is no bronchodilator reversibility, it is either a COPD or bronchiectasis. Okay, so what is bronchodilator reversibility? Bronchodilator reversibility means when patient is coming with symptom, you are giving a meter dose inhaler of the bronchodilator. So if you are giving a bronchodilator and after giving the bronchodilator, you will see how much the FEV1 is improving. If it is improving more than 12% or there is an increase more than 200 ml, this would mean that there is a bronchodilator reversibility. You are giving a meter dose inhaler or an inhalation of a bronchodilator like salbutamol, and if there is a improvement of FEV1 more than 12% or 200 ml, you say there is a bronchodilator reversibility. Now, if it is normal or reduced, normal to increase, there are two possibilities. One possibility is patient is having restrictive lung disease. That is one possibility. What is the second possibility? The second possibility is patient is absolutely normal. Patient is absolutely normal. So how to differentiate? Is it a restrictive lung disease or is it normal? You please look at the FVC, forced vital capacity. If the look at whether the forced vital capacity is less than 80% of predicted. This is a very, very important flow chart. I want everyone to draw along with me. You'll be able to make a diagnosis easily. So look whether it is no or it is yes. If it is no, then the patient is a normal individual. It's a normal individual. But if the answer is yes, then it means it is a restrictive lung disease. It is a restrictive lung disease. Is it clear? It is a restrictive lung disease. So I hope it is clear for you how to differentiate. Okay, it is a restrictive lung disease. Okay, restrictive lung disease. Okay, so is it clear for you? Okay, right. Restrictive lung disease. This is how you will, understand. Okay, now coming to the next table, next picture of the different types of flow volume loops in upper airway obstruction. You can see there are flow volume loops A, B, C, and D. The first flow volume loop is a normal flow volume loop. The second flow volume loop, now remember in a flow volume loop, this is the expiratory component, this is the inspiratory component. If there is a flattening of the inspiratory component with a normal expiratory component, that is seen in variable extrathoracic obstruction as in case of vocal cord palsy. Okay. The third one is where the inspiratory part is flattened, but the expiratory part is flattened, but the inspiratory part is normal. It is seen in variable intrathoracic obstruction like tracheomalacia. And finally, when you get a fixed airway obstruction, you get a flattening of both the expiratory and the inspiratory part. This is in tracheal stenosis. So I hope you are clear with the flow volume loop patterns. Okay, flow volume loop patterns. Okay, so I hope you are comfortable regarding this. Okay, so give me a thumbs up if you are understanding. Just give me a thumbs up. Give me a thumbs up if you're getting this. Just waiting for your comments. Okay, right. Next is some points about diffusion capacity of carbon monoxide or DLCO. This is also a PYQ. So what is DLCO? We know that carbon monoxide is having a high affinity for hemoglobin. So the DLCO or the diffusion capacity of carbon monoxide, this would depend on the integrity of the alveolo-capillary membrane and also the gas exchange surface area. So that is what would determine the diffusion capacity of carbon monoxide. So you must know what are the conditions characterized by decrease in the DLCO and what are the conditions characterized by normal DLCO. A decreased DLCO happens in interstitial lung disease, anemia, emphysema, and pulmonary vascular diseases like pulmonary hypertension and pulmonary vascular disease. Okay, this is like pulmonary hypertension. Okay, this would mean pulmonary hypertension. You can write pulmonary hypertension. Okay, pulmonary hypertension. Whereas increased DLCO, this is seen in polycythemia and pulmonary hemorrhage. Polycythemia and pulmonary hemorrhage. Okay, right. And which condition will you get normal DLCO? Can you get a normal DLCO in any lung conditions? In case of asthma and chronic bronchitis. Asthma and chronic bronchitis. Asthma and chronic bronchitis. Are you clear regarding this? Again, very, very important. Okay, next question. Which of the following, they are associated with type 1 respiratory failure except? So can you answer this? Pneumonia, ARDS, myasthenia gravis, pulmonary embolism. So you've got type 1 respiratory failure and type 2 respiratory failure. Type 1 would be an oxygenation failure and type 2 would be a ventilation failure. So out of this, pneumonia is characterized by type 1 respiratory failure. ARDS is also type 1 respiratory failure. Pulmonary embolism is also type 2 respiratory failure. But myasthenia gravis is characterized by type 2 respiratory failure. So myasthenia gravis, kyphosis, obesity, ankylosing spondylitis, Guillain-Barré syndrome, they are all characterized by type 2 respiratory failure. Answer is option C. Some other important spotter questions that have been asked before in FMGE exam. Number 1, if you get Horner syndrome with hand muscle wasting with a mass involving the lung apex, what would be your answer? You can see there is a mass involving the lung apex. You get Horner syndrome and hand muscle wasting. What is the answer? The answer is Pancoast syndrome. Okay, you've got a Pancoast tumor involving the lung apex, which can cause damage to the cervical sympathetics, and you can also have hand muscle wasting along with pain along the inner border of the arm. What about deep sulcus sign? So if you look at this, what is the condition where you get a deep sulcus sign? Can you tell me? Patient with acute onset breathlessness. You can see there is a collapsed lung margins here and you get a deep sulcus here. What is the condition? Pneumothorax. Pneumothorax, right? Okay. What about barcode sign? Barcode sign, also known as stratosphere sign, is a finding in pneumothorax. This is also an ultrasound finding in case of pneumothorax. So pneumothorax, ultrasound finding. In a normal lung, if you do the ultrasound, again, you get a seashore sign where there is a positive motion of the lung, and whereas in pneumothorax, you're not having the motion of the lung. You get the barcode sign, also known as the stratosphere sign. Okay, right. Okay, now next is the holly leaf sign. Can you tell me which is the occupational lung disease which is characterized by calcifications involving the pleura? So you will get pleural calcifications, and such large calcifications can produce the so-called holly leaf sign, which is a feature of asbestosis. This would be a feature of asbestosis. Holly leaf sign, asbestosis. And what would be another occupational lung disease which would have this sort of a finding where the CT thorax would show, number 1, ground glassing. If you ask me, is there ground glassing? Definitely yes, there is ground glassing. But along with ground glassing, you can also see there is some sort of a thickening that is involving the interlobar and interlobular septa, which is seen in silicosis. So crazy paving pattern is a feature of silicosis. And what is the X-ray finding in silicosis? You get egg-shell calcification. You get egg-shell calcification. Egg-shell calcification. Okay, right. Now, if you get a patient with a clinical scenario of a high-grade fever, halitosis, and cough with productive sputum, you with the X-ray showing a cavity with an air fluid level What is the diagnosis? Yes, you have answered correctly. It is lung abscess. It is lung abscess. It is lung abscess. Okay, lung abscess. Clear? Okay. Right. Next is, what is Silhouette sign? So what is Silhouette sign? Silhouette sign is seen when there is a consolidation involving the right middle lobe. So when there is a consolidation involving the right middle lobe, you can see that there is an obscuration of the heart border. So this is called a Silhouette sign, which is seen in right middle lobe consolidation. So Silhouette sign is seen in right middle lobe consolidation. Right middle lobe consolidation, you get Silhouette sign. Right middle lobe consolidation, you get Silhouette sign. Next is, what is bulging fissure sign? So when you get a pneumonia with a predominant upper lobe involvement, which would cause the bulging of the horizontal fissure downwards, this is called bulging fissure sign. This is commonly associated with Klebsiella pneumoniae. This is commonly associated with Klebsiella pneumoniae. Klebsiella pneumoniae. Okay, that is bulging fissure sign. Okay, done. That's it. Next, you look at this. If you get a 40-year-old smoker male patient presenting with high-grade fever, cough, diarrhea, confusion, chest X-ray shows bilateral pneumonitis, what is the pathological agent suspected? So this is a scenario of a pneumonia. But what is the interesting point here? The patient is having diarrhea and confusion. So can you tell me which agent that can cause pneumonia is commonly going to produce diarrhea, confusion, and sometimes hyponatremia? Can you answer? Sean, Rupali, Aditya, what is the answer? It is Legionella. It is Legionella. Okay, Legionella can cause an atypical pneumonia with diarrhea, confusion, and hyponatremia, right? Okay. Next, transferrin saturation decreases in which condition? So what do you think? In which of the following conditions will transferrin saturation decrease? So what is transferrin saturation? Transferrin saturation means serum iron divided by total iron binding capacity into 100. Serum iron divided by total iron binding capacity into 100. This is called transferrin saturation. So they're asking, which condition will transferrin saturation decrease? So in iron deficiency anemia, when the serum iron decreases and TIBC increases, so what is going to happen? Transferrin saturation decreases. So when does transferrin saturation increase? In all iron overload states. In all iron overload states, hemosiderosis, hemochromatosis, there is increase in transferrin saturation. Pernicious anemia, nothing to do with transferrin saturation. Okay, right. Which of the following is an indicator for poor prognosis in multiple myeloma? So if you look at multiple myeloma patients, can you tell me which is an indicator for poor prognosis out of the options that have been listed? Serum beta-2 microglobulin, serum creatinine kinase, serum calcium, and serum glucose. Anyone can answer? Okay, Ritik, Chaitanya, Rituraj, what is the answer? Yeah, it is serum beta-2 microglobulin. Serum beta-2 microglobulin is the answer. It is an indicator for poor prognosis in multiple myeloma. So high value of serum beta-2 microglobulin would mean a poor prognosis. Understand? Yes. Okay. Now, if you get a scenario of a patient with a peripheral smear, patient is mostly a strict vegetarian, having anemia, fatigue, and the having features of fatigue. The blood investigation is showing a hemoglobin which is low. So there is a decreased hemoglobin. There is increased MCV, and the peripheral smear showing macrocytes plus hyper segmented neutrophils. What will you think of? It is B12 deficiency. Okay, you will think of B12 deficiency. You get macrocyte plus hyper segmented neutrophil. Okay. Now, if the peripheral smear shows a garden party appearance, which you can see that there are neutrophils in various stages of maturation. The blast, a few blasts here and there. You can see myelocyte, metamyelocyte. What is the diagnosis? It is chronic myeloid leukemia. There is a garden party appearance. If you get a convent girl appearance, what is the diagnosis? With similar appearing cells, it is seen in CLL, chronic lymphocytic leukemia. And in CLL, you can also see certain cells which are smeared out, which are damaged during, the smear formation. And what do you call this? These are known as what? In CLL, you get smudge cells. You get smudge cells. Okay, you get smudge cells. Understand? And what about finding of ORODs? ORODs are an important feature of AML-M3. So AML-M3, you get ORODs. This again is a PYQ for FMGE exam. Okay. Now always remember, if you get a clinical scenario of a patient who is HIV positive and is having a swelling involving the hard palate, what would be the diagnosis? Swelling involving the hard palate, what would be the diagnosis? The answer is Kaposi sarcoma. The answer is Kaposi sarcoma. The answer is Kaposi sarcoma, which is caused by HHV8. So HHV8 producing Kaposi's sarcoma. Okay, clear. Right. Now, if you get unilateral vesicular lesions in a dermatomal pattern, what would it suggest? It is suggesting herpes zoster. It is suggesting herpes zoster. When you get vesicular lesions in a dermatomal pattern, it is herpes zoster. Okay, right. Next is if you get a combination of diarrhea, dementia, and dermatitis. This combination is seen in pellagra. Okay, this combination is seen in pellagra. Okay, right? Okay. Next, Burtonian lines, which are seen on the gums. It is seen in lead poisoning. Burtonian line seen in lead poisoning. This is also a FMG PYQ. Okay. What about raindrop skin pigmentation? It is seen in arsenic toxicity. Arsenic toxicity. Now, when there is a lead toxicity, when the patient has a motor neuropathy, when the patient has a neuropathy, is it predominantly motor neuropathy or sensory neuropathy? It is predominantly a motor neuropathy that is produced by lead. And what about arsenic? Arsenic is going to produce mainly a sensory neuropathy. Sensory neuropathy. If patient is having autonomic storm with priapism, a severe autonomic storm with priapism, what is the diagnosis? So severe autonomic storm, that is excessive salivation you are having, and there is a painful penile erection. So when there is an autonomic storm with priapism, what is the diagnosis? The diagnosis is what? Anyone can tell me? Scorpion sting. So again, a PYQ, they have asked the clinical scenario of a patient with so much of watery discharge from the mouth with priapism. Answer is scorpion sting. Then coming to some important points from endocrinology. Okay, endocrinology. So treatment, yes, as you rightly said, Aditya, the treatment would be prazosin. The treatment would be prazosin. Okay, and you also have got antidote. You also have got antidote also available. Okay, antivenom. Okay, now coming to endocrinology case scenarios. Suppose you get a clinical scenario of a patient who is having hypertension, but there is a worsening of hypertension with beta blockers. What condition will you think of? Worsening of hypertension with beta blockers. So patient was having hypertension, he was prescribed beta blockers, but there is worsening of hypertension with beta blockers. This is seen in pheochromocytoma. So always remember, for pheochromocytoma, you should not be giving beta blockers as first-line antihypertensive agent, because there can be unopposed alpha action resulting in increase in the blood pressure. Okay. Next point, when you get episodic hypertension, palpitation and hypertension, what is again the diagnosis? This would again be a pheochromocytoma. This would again be a pheochromocytoma. If patient has a moon facies with obesity, striae, and a proximal muscle weakness, as Ritik correctly said, it is Cushing's syndrome. This would be a Cushing's syndrome. Cushing's syndrome. If patient has a resistant hypertension with hypokalemia, can anybody tell me if patient is having an endocrinological condition where there is a resistant hypertension, very high BP with hypokalemia, what condition? Very good, Sabin, you're right, Conn's syndrome. This would be Conn's syndrome. This would be Conn's syndrome. Now, I want to see how many of you are going to answer the next 2 points. Number one, patient with hypotension, hyponatremia, and hyperkalemia. The second one would be weight loss, fatigue, no hyperpigmentation, low cortisol, and normal potassium. What about first one? What about second one? Let me see who's smart enough to answer, both of them. Only if you understand your concept, you will be able to answer. Which one is primary adrenal insufficiency? Which one is secondary adrenal insufficiency? The first one would be what? The first one would be a primary adrenal insufficiency. A primary adrenal insufficiency. That is your Addison's disease. Because in primary adrenal insufficiency, you are having a hypotension, hyponatremia, and hyperkalemia. Remember, primary adrenal insufficiency would have hyperkalemia. And this patient also can have pigmentation. This is also possible. Primary adrenal insufficiency can have pigmentation. But if patient is having weight loss, fatigue, which are non-specific symptoms, but there is no hyperpigmentation, but the cortisol is low and the potassium is normal. Now, if the potassium is normal and there is no hyperpigmentation, see, for producing a hyperpigmentation, you need to have increase in ACTH, which would have an MSH-like activity. So if there is a secondary adrenal insufficiency can have hyponatremia, possible, but will not be having hyperkalemia. The potassium will be normal in secondary adrenal insufficiency. So primary adrenal insufficiency is a problem in the adrenals and secondary adrenal insufficiency is a problem in the pituitary. Next one, if patient is having hypokalemia, metabolic alkalosis and hypocalciuria, then what? Hypokalemia, metabolic alkalosis, hypocalciuria. Can you tell me what is the condition you are dealing with? It is Barter's syndrome. Barter's syndrome. That is the NIS condition. What about the next condition? Patient having hypertension, hypokalemia, alkalosis, and low aldosterone. What is the diagnosis? It is Liddle syndrome due to epithelial sodium channel activation. Liddle syndrome. Now, if patient is having polyuria with low plasma osmolality and low urine osmolality, what do you think is the diagnosis? What do you think is the diagnosis? There is polyuria. Is it diabetes insipidus or is it psychogenic polydipsia? So this would be a psychogenic polydipsia. This would be a psychogenic polydipsia. Okay, psychogenic polydipsia. The next one, a polyuria with increasing urine osmolality on water deprivation. So if you're going for a water deprivation test and there is a progressively increasing urine osmolality, then what is it? Then what is it? This is also a psychogenic polydipsia. Okay, there is a psychogenic polydipsia. There is a psychogenic polydipsia. Okay, where there is an increasing urine osmolality on water deprivation, it is psychogenic polydipsia. Okay, suppose if there is a polyuria with high plasma and low urine osmolality with no response to desmopressin, then what would be the diagnosis? There is a polyuria with high plasma osmolality, low urine osmolality, no response to desmopressin. It would be a nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. Okay, nephrogenic diabetes insipidus. Okay, so somebody is asking, sir, please explain the second last. So polyuria with increasing urine osmolality. See, psychogenic polydipsia means the patient is keeping on drinking lots of water, and because of that his urine osmolality is high. When you do the water deprivation test in a patient with psychogenic polydipsia, when you deprive him of water, what will happen? He's not drinking water. So previously his urine osmolality was low. Now when you are depriving water, his urine osmolality would increase. I hope Dr. RBC, I liked your name, Dr. RBC, hope you are clear with this. Okay, are we done with this? Next, all the following are criteria for the diagnosis of diabetic ketoacidosis except, okay, except, is it serum glucose more than 250? So is it pH less than 7.3? A serum bicarbonate less than 15 milliequivalents? Or is it a serum potassium less than 3.5 milliequivalents per liter? What do you think? All are criteria for the diagnosis of diabetic ketoacidosis except. What about point number 1? Serum glucose more than 250. Is it a part of the diagnostic criteria? Yes, it is a part of diagnostic criteria. pH less than 7.3. Is it a part of diagnostic criteria? Yes, patient will be having metabolic acidosis. That is also correct. Serum bicarbonate less than 15 milliequivalents per liter. Is it a part of the diagnostic criteria? Yes, it is a part of the diagnostic criteria, and you will have metabolic acidosis. Okay. Now the last one, serum potassium less than 3.5 milliequivalents per liter. So this is hypokalemia. Now tell me, can hypokalemia or is hypokalemia a manifestation of diabetic ketoacidosis? Or can hypokalemia occur in diabetic ketoacidosis? Remember, you can have hypokalemia in diabetic ketoacidosis, but it is not because of the diabetic ketoacidosis. In case of diabetic ketoacidosis, what happens? What happens is you are giving the patient insulin for treatment. So diabetic ketoacidosis, the disease is not going to produce hypokalemia. As Dr. Yash Modi is rightly saying in the comment section, when you are giving the patient insulin, what happens in diabetic ketoacidosis? What is most important? You give fluids. Also, you will give insulin. Insulin has a property, and what is that property? It will cause redistribution of potassium. So whatever potassium is there in the extracellular fluid will come to the intracellular fluid. This will produce hypokalemia. So this is a manifestation of treatment rather than because of the diabetic ketoacidosis, and hence the answer is option D. Okay, hence the answer is option D. Okay, I hope you're clear with this. Next is, which of the following is not given in thyroid storm? What do you think? In case of thyroid storm, which of the following is not given? What do you think? Can you give propranolol, beta blocker? Can it be given in thyroid storm? Yes or no? What do you think? What do you think is the best answer for this? What do you think is the best answer for this? Yeah. So first option is propranolol. So propranolol is a beta blocker, which definitely can be given in case of a thyroid storm, because you know that beta blocker will prevent the conversion of T4 to T3, and it definitely can be given in case of thyroid storm. What about Lugol's iodine? So Lugol's iodine can also be given in case of thyroid storm. That is also given as a part of treatment. Aspirin is not given in thyroid storm. In fact, it is contraindicated as well. But what about paracetamol? You know that in case of the thyroid storm, the patient is likely to have high body temperature. So if there is a high body temperature, definitely you can give the patient paracetamol. So out of the options given, aspirin is not given in case of thyroid storm. Answer is option C, aspirin. Now, if you get a clinical scenario of a patient, a child with coarse facies and umbilical hernia, what do you think will be the diagnosis? He is having a macroglossia as well, an enlarged tongue. There is an umbilical hernia, coarse facies. This could be a congenital hypothyroidism. Congenital hypothyroidism. Congenital hypothyroidism. Right? Okay. Now, if you get a scenario of a patient with mucosal hyperpigmentation with vitiligo, what could be the diagnosis? Mucosal hypopigmentation with vitiligo, what could be the condition? This is Addison's disease. Addison's disease. This would be Addison's disease. So why the patient is having vitiligo? Remember, Addison's disease, there is autoimmunity. So one of the causes of Addison is autoimmune. So always remember, vitiligo is a common feature of various autoimmune disorders that you should understand. See, why I am teaching you in this sort of format, you should understand. When you are coming near your FMG exam, let me tell you something. I'm telling you with this experience of having written multiple entrance exams like PG entrance exam, super specialty entrance exam. See, it is all about identifying keywords in the question. It is not just mugging up lot of information. Who is a good student? A good student is someone who can identify the keywords which are given in the question. So I want all of you, when you are revising, to focus on the keywords. That is why when I made this revision session also, if you look at the PDF now, which is there in your hands, the PDF that is there is full of high points that you can quickly revise. Even the day before the exam, you can just scroll through this. Everything is one-liner points, but given from a clinical perspective. Because in your exam, you are likely to get scenario-based questions. And in medicine, majority of the questions that you're going to get will be integrated with other subjects. So you've got to link with other subjects and learn medicine. That is what you've got to understand. Okay, right. So please go through this PDF again and again. You'll get lots of questions from this. Okay. Now, next is, can you tell me which multiple endocrine neoplasia is associated with this skin condition? Men is very, very important. Which multiple endocrine neoplasia is associated with cutaneous lichen amyloidosis? It is MEN2A. MEN2A is associated with cutaneous lichen amyloidosis, right? And when you get a scenario of a patient with coarse facies, frontal bossing, and maybe some X-ray features. Can you tell me what are the X-ray features of this condition? Coarse facies, frontal bossing, think of acromegaly. And what are the important, findings in acromegaly? One is when you look at the phalanges, you get spade-like phalanges. You get spade-like phalanges. And there is increase in the heel pad thickness. Increase in the heel pad thickness. Okay, these are the findings. And acanthosis nigricans, remember, can be a part of metabolic syndrome. So patient with metabolic syndrome, an important finding is acanthosis nigricans. Can you see this? This is acanthosis nigricans seen in metabolic syndrome. As Dr. Sachin is correctly telling, this is an indicator of insulin resistance. It is an indicator of insulin resistance. Okay, right. Now, what about this test? Can you tell me what is this used for? This is used for detection of which condition? Diabetic neuropathy. So this condition is called this test is known as monofilament test. Using filaments, you are touching the sole of the feet and asking the patient whether you can feel the sensation. This is called monofilament test, used for testing diabetic neuropathy. Okay, diabetic neuropathy. Next, some important points from the nephrology. So if a patient is there who is having cola-colored urine, mostly child after infection, maybe sore throat, patient develops a cola-colored urine. So patient is having hypertension, cola-colored urine. You are doing a renal biopsy. When you do a renal biopsy and you are doing electron microscopy, of the renal biopsy sample and you are getting a subepithelial hump. What is the likely diagnosis? This is post-streptococcal glomerulonephritis. So after a streptococcal infection, the patient can develop glomerulonephritis. And the characteristic electron microscopy finding is the presence of subepithelial humps. Very, very important. This is a PYQ. And collapsing variant of FSGS. So the focal segmental glomerulosclerosis, again, very, very important. See, what is the peculiarity of FSGS? If you look at the various glomerular disorders, what are the important glomerular disorders that can present with nephrotic syndrome? So one of the glomerular disorder that can present with nephrotic syndrome is minimal change disease. The next condition that can present with nephrotic syndrome is FSGS. FSGS. And what is the next condition? You can also have membranous glomerulonephritis. Okay, so these are conditions that can present with nephrotic syndrome. Out of this, if you are asked in children, what is the most common cause of nephrotic syndrome? It is minimal change disease. In adults, what is the most common cause of nephrotic syndrome? It is FSGS. In adults, it is FSGS. Yes, children, it is minimal change disease. Adults, it is FSGS. Next, if you're having nephrotic syndrome, which is present in elderly, it is membranous glomerulonephritis. Membranous glomerulonephritis. Okay. Right. So I'm asking you a question about FSGS. So if you get a collapsing variant of FSGS, can you tell me the variant of FSGS, which is a collapsing variant of FSGS, is associated with which condition? It is associated with an infection that is HIV. So HIV associated nephropathy, which is abbreviated as HIVAN. This is commonly associated with the variant of FSGS known as collapsing variant of FSGS. Collapsing variant of FSGS. Okay, right. And next is spike and dome pattern in renal biopsy. This is an expected question from pathology as well. Can you tell me what is the condition where you get spike and dome pattern in a renal biopsy? Spike and dome pattern. This is seen in membranous glomerulonephritis. So in membranous glomerulonephritis, you get a spike and dome pattern. Zobia, you're absolutely right. It is membranous glomerulonephritis. Okay. Suhaib, it is in PSDN. It is electron microscopy is showing the subepithelial hump. Okay, right. Parthasarathi, it is the tram track appearance that is seen in MPGN. So in MPGN, you get the tram track appearance. What about the presence of cast? When you get muddy brown granular cast, so what condition will you think about? Muddy brown granular cast is seen in which condition? Okay, it is seen in acute tubular necrosis. So acute tubular necrosis mostly is due to toxins, which can be endogenous toxins or exogenous toxins. So exogenous toxins like say contrast, when you administer contrast like iodinated contrast, it can cause acute tubular necrosis, or endogenous toxins, which can be uric acid, hemoglobin, myoglobin, that is endogenous toxins. So you get muddy brown granular cast in acute tubular necrosis. Can somebody tell me in which condition you get broad waxy cast? Which condition you get broad waxy cast? This is also a PYQ. Broad waxy cast is seen in case of chronic kidney disease. Chronic kidney disease, you get broad waxy cast. Okay, important. Okay, and in which condition you get RBC cast? RBC cast in which condition? RBC cast in glomerulonephritis. So RBC cast is seen in glomerulonephritis. So in glomerulonephritis, you will have dysmorphic RBCs and RBC cast. Okay. If you look at the kidney and there are cysts in the kidney, you have a patient with image showing cyst in the kidney. So you have got larger cyst with cyst more in the cortex compared to medulla. And also if you have got smaller cyst, more in the medulla compared to cortex. You have to know this comparison. If you have got very large cyst with more cyst in the cortex compared to the medulla, this is likely to be autosomal dominant polycystic kidney disease. If the cysts are relatively smaller in size, you can see this is an image. This is the full gross image. This is the cut open section. You can see There are large cysts which are present in both cortex and medulla, but more towards the cortex. But when you get so much of cyst in the polycystic kidney disease, the corticomedullary differentiation is lost. You may not be able to exactly point out what is the cortex and what is the medulla in this. And when you get smaller cysts, which are more in the medulla compared to the cortex, so this would be a autosomal recessive polycystic kidney disease, ARPKD. Okay. And another point of this ARPKD is that you will have certain radial and linear striations can be seen. Can you see these small striations? So you can see such sort of radial, linear or radial striations. Radial striations can be seen over the cortex. Okay, right. And what condition you get? Lindsay nail or half of nail, where the proximal part is pale and the distal part is dark. The proximal part is pale because of the anemia, and the distal part is dark because of the melanin deposition. This is a feature of chronic kidney disease. Okay, right. Next is renal biopsy, which is showing a linear pattern of deposition of IgG and C3 in immunofluorescence. What do you think? This characteristic finding is seen in which condition? This is seen in Goodpasture syndrome. This is seen in Goodpasture syndrome. Renal biopsy with linear pattern of IgG and C3, Goodpasture syndrome. Understood? Right. Next, renal biopsy showing starry sky appearance in immunofluorescence. Let me see who's going to answer. This is seen in case of post-streptococcal glomerulonephritis. PSGN, you get starry sky appearance in immunofluorescence. Okay, right. So let us look at the next question. A 10-year-old boy is presented with follicular tonsillitis. So he had some sort of tonsillar infection. He was prescribed on antibiotics. After a few days, the patient developed a decrease in urine output, a rash, and periorbital edema. Peripheral smear shows eosinophilia, and urine microscopy shows WBC cast. What is the likely diagnosis? What do you think? What is the likely diagnosis? So he's having some sort of a follicular tonsillitis for which he took some antibiotics. And it is after the antibiotic intake, his urine output has decreased. So urine output can be decreased in kidney conditions. But you look at this kidney condition where there is rash, there is periorbital edema, and the peripheral smear is showing eosinophilia, and urine microscopy shows WBC cast. What is the answer? So this is, I can see some of them commenting as pyelonephritis, many of them saying option A. See, why did you say this pyelonephritis? Why did you say pyelonephritis? See, the patient is prescribed some antibiotics, and after antibiotic is developing these features, which means it is something due to the antibiotics. So whenever you get a acute kidney injury where you have decreased urine output, rash, which is the condition associated with rash? It is allergic interstitial nephritis, which is also called acute interstitial nephritis, which can be induced by drugs. Various antibiotics can cause allergic interstitial nephritis, which can be a beta-lactam antibiotic. This can be a sulfonamide, which can be a linezolid, drugs like linezolid. It can be a quinolone. So all these drugs, they are notorious for producing allergic interstitial nephritis. So this is the likely diagnosis, wherein the peripheral smear can show eosinophilia. Obviously, it is a allergic response. So Parthasarathi, your doubt is, sir, there is WBC cast. See, WBC cast can be seen in pyelonephritis, but tell me, Partha, is WBC cast specific for pyelonephritis? WBC cast can be seen in many conditions: pyelonephritis, glomerulonephritis, allergic interstitial nephritis, multiple. So in here, you have to see the totality of the question. Okay. And Sachin is saying, yes, NSAIDs also can cause allergic interstitial, but here they have specifically said antibiotics. But other drugs like NSAIDs, certain diuretics, certain anticonvulsants can also cause allergic interstitial nephritis. Answer is option B. Next question. So I hope it is clear. Give me a thumbs up if you are clear. Okay. So Priyanshu is asking, why does he have WBC cast in the urine? As I told you, WBC casts are not specific. You can see it in allergic interstitial nephritis also. Okay, right. Next question, what is the initial step in the development of high turnover CKD mineral bone disease? So when you talk about chronic kidney disease, there are two types of mineral bone disease. That is, mineral bone disease is the skeletal manifestation of CKD. So you have got the high turnover disease in CKD, high turnover, and you have got the low turnover or low bone turnover disease, which is your adynamic bone disease. So there are two types, and you tell me what is the first step in the development of CKD. Is it hyperphosphatemia? Is it hyperkalemia? Is it hypocalcemia? Is it FGF23? So when a patient develops a chronic kidney disease, mineral bone disease, which is your renal osteodystrophy. So if you look at the options, all the options can be seen in chronic kidney disease. You can have hyperphosphatemia, hyperkalemia, hypocalcemia, increase in FGF23. But what is the first step that results in the skeletal manifestation? Somebody is answering hypocalcemia, somebody is answering increase in FGF23. Nobody has answered correctly so far. The answer is option A, hyperphosphatemia. So in chronic kidney disease, what happens is, the first step that happens is an increase in the phosphate. Now, it is when there is an increase in the phosphate, then there would be an increase in FGF23. So is there an increase in FGF23? Yes. But is it the next step? No, you are having an increase in the phosphate. And only after that, there is an FGF23. And why the FGF23 is increasing? FGF23 helps in increasing the excretion of phosphate. FGF23 is phosphaturic. It helps in the excretion of phosphate. So the body is producing FGF23 to excrete the excess phosphate. So on one hand, it causes urinary excretion of phosphate. That is good. It causes urinary excretion of phosphate. But on the other hand, it will inhibit vitamin D. When it inhibits vitamin D synthesis, what happens? You will have hypocalcemia. And when there is a hypocalcemia, what happens? The parathyroid production is increased. There is secondary hyperparathyroidism. So the secondary hyperparathyroidism is responsible for the renal osteodystrophy. Now, if you look back, what is the first step that was responsible? Was it decrease in calcium? Was it increase in FGF23? Was it increase in phosphate, or was it, increase in potassium? Answer is option A. Please give me a thumbs up if you're confident on this. The reason for the chronic kidney disease mineral bone disease or renal osteodystrophy. Let's go to the next question if you're clear with this. Okay, right. So the next question is, choose the incorrect statement about renal tubular acidosis. About RTA, what is the incorrect statement? What do you think? RTA is a very, very important topic for FMG exam. You have to learn it properly and go to the exam. First option, renal tubular acidosis type 2 is associated with bicarbonaturia. Is it correct or false? It is correct. See, in type 2 RTA, which is the proximal RTA, there is a defective bicarbonate reabsorption, and because of which there is a bicarbonaturia. So that option is correct. RTA type 4 is associated with hypokalemia. This is wrong. Because there is an aldosterone resistance, RTA type 4 is associated with hyperkalemia and not hypokalemia. Next option, RTA type 2 may present with Fanconi's syndrome. What do you think? Proximal RTA, Fanconi's syndrome. Yes, it is also true. What is a Fanconi's syndrome? Do not confuse Fanconi's syndrome with Fanconi's anemia. In case of Fanconi's syndrome, this is going to happen in RTA type 2. There is a generalized dysfunction of the proximal convoluted tubule. So not only in a Fanconi syndrome, it is a more severe form of proximal renal tubular acidosis, where there is defect in not only the bicarbonate reabsorption, but there is also increased excretion of glucose, amino acids, phosphates. So that is also correct. The fourth option, RTA type 4 is due to aldosterone resistance, is also a true statement. It is due to aldosterone resistance. My answer would be option B. Okay, I hope it is clear. Next, a simple question on acid-base balance. 35-year-old patient presented with nausea, vomiting, diarrhea. ABG results indicate a pH of 7.55, PaCO2 of 50, bicarbonate of 44. What is the acid-base disturbance? So look at this. pH is 7.55. The arrow goes up. PaCO2 of 50. The arrow goes up. What is the normal pH? 7.4. Carbon dioxide 40, bicarbonate 24, and bicarbonate is 44. Again, the arrow goes up. So it is a alkalosis. So I've already eliminated option A and option C. Is it respiratory alkalosis or metabolic alkalosis? Look at this. The change in pH in relation to the bicarbonate and PaCO2 is in the same direction. So what is going to be the answer? The change in pH with carbon dioxide and bicarbonate is in the same direction. What is the answer? It is metabolic alkalosis. Remember, whenever the change in pH and the change in PaCO2 and bicarbonate, it is in same direction, it is a metabolic problem. And if it is in opposite direction, pH is going up, whereas PaCO2 and bicarbonate is going down, it is respiratory. And also you can imagine, patient is not having any sort of respiratory problem. He is having a metabolic problem, nausea, vomiting, diarrhea. This is a metabolic alkalosis. Yes or no? This is D. Okay. So this is a metabolic alkalosis. Okay. Right. Metabolic alkalosis. So why is the PaCO2 increase? PaCO2 is 50. You might ask me, sir, PaCO2 increased is in this acidosis. It is a compensatory response. There is a carbon dioxide retention. Because the patient is having a metabolic alkalosis, there is a carbon dioxide retention. Next, according to the KDIGO staging of chronic kidney disease, the GFR of stage 3B is it GFR 15 to 29, 30 to 44, 45 to 59, or is it 60 to 89? What do you think? Remember, according to the KDIGO, this is the staging of chronic kidney disease. You have got G1, G2, there is G3A and G3B, there is G4 and G5. Okay, so what about G1? In G1, the GFR is more than or equal to 90. In G2, 60 to 89. G3A, 45 to 59. In G3B, 30 to 44. G4, 15 to 29, and G5 less than 15. So G5 is the stage of kidney failure. So what is going to be the answer? Answer is 30 to 44, which would be G3B. Correct or not? G3B. Okay. So answer is option. They're asking about G3B. Okay. Is it clear? Okay. So look at this. It is G3B and not G3A. Okay. That they're asking. Okay. Right. Next is, what is the best therapy for hepatorenal syndrome? So what is hepatorenal syndrome? Patient is having a hepatic problem and he's having a secondary functional affection of the kidney. Okay, it is a secondary functional affection of the kidney that is happening. It is not primarily a disease of the kidney. It is a primary disease of liver with secondary affection of the kidney. So what is the treatment? So hepatorenal syndrome, you can use different agents. You can use combination of albumin plus octreotide, and you can also use midodrine. You can also use vasoconstrictors like norepinephrine, terlipressin, but they're asking about the best therapy. The best therapy for hepatorenal syndrome, as many of you said, it is liver transplantation. Option B, that would be the answer. Next question, which of the following serological patterns would suggest hepatitis B immunization? So the patient has received a hepatitis B immunization. What do you think? So hepatitis B immunization means what? The patient has got an antibody titer. So antibody titer should be positive. So I'm already eliminating option A and option B because in both these options, the anti-HBs titer is negative. So immunization means antibody should be positive. Now, what about option C and option D? So what could this be? Option C and option D, both of them HBsAg is negative. But you look at this, in option C, IgM anti-HBC is negative. And option D, IgG anti-HBC is positive. Now, if the IgG anti-HBC is positive, it is indicating what? Can somebody answer? Tarun, Shuhaib, Surpi, Rupali, Aishi, Chaudhary, Shuhaib, can you answer? This is suggestive of some sort of a remote infection. There is some sort of a remote infection is what is indeed. It is not vaccination. He had some old infection, as you rightly said, Adi, wonderful. Okay, so what about option C? That would be my best answer here, which is option C. This is very, very important. Serological patterns of hepatitis C is very, very important. In all my lectures also I've highlighted hepatitis B, serological patterns, very important for your exams. Okay, now coming to this one. 35-year-old chronic liver disease patient present to the emergency department with features of decompensation. Which of the following is not a component of the MELD score? So MELD score is model for end-stage liver disease. Model for end-stage liver disease, which is important in assessing the prognosis of patients with chronic liver disease. So they're asking, which of the following is not a part of MELD score? The first option is creatinine. Definitely creatinine is a part of it. Bilirubin definitely is a part of it. The prothrombin, PTINR, is definitely a part of it. But albumin is not a part of the MELD score. My answer would be option D. That would be albumin. Yes or no? Yes, albumin. Right. Next question. A 35-year-old male presents with painless jaundice. Liver function test shows total bilirubin of 12 and a direct bilirubin of 10. He undergoes liver biopsy, which shows the following. What is the most likely diagnosis? So you can see that the patient has got a hyperbilirubinemia. And since the direct bilirubin is 10, is it conjugated or unconjugated? Conjugated hyperbilirubinemia. When there is a conjugated hyperbilirubinemia with this sort of pigments which are due to certain epinephrine metabolites, what should you think of? Which liver disease? You should think of a type of conjugated hyperbilirubinemia associated with black pigmentation, which is Dubin-Johnson syndrome. The answer would be option D, that is Dubin-Johnson syndrome. Option D would be the answer here. Okay, right. So that is clear. What about string sign of Cantor? Very, very simple. PYQ asks multiple times, seen in which condition? Crohn's disease due to the involvement of the terminal ileum. Due to the involvement of the terminal ileum, right? Okay. Next, in comparison with ulcerative colitis, choose the true statement about Crohn's disease. Option A, continuous pattern of involvement rather than skip lesions. Remember, this option is actually false because skip lesions are actually the feature of Crohn's disease. They're asking choose a true statement about Crohn's. The first is wrong. Continuous pattern of involvement is ulcerative colitis. Skip lesions is Crohn's disease. Commonly manifest hematochezia. This is not a feature of Crohn's. It is again a feature of ulcerative colitis. No increased risk of colon cancer. Look, both Crohn's disease and ulcerative colitis have got increased risk of colon cancer. Okay. But the risk is more with which condition? It is definitely due to ulcerative colitis. But the option says no increased risk. That is wrong. There is some increased risk with Crohn's disease also. But perianal fistulas are present. This would be a correct answer. That would be my best answer. Option D. What is the differentiating feature between irritable bowel syndrome, IBS, and organic GI disease? So IBS would mean irritable bowel syndrome. So how to differentiate irritable bowel syndrome and an organic GI disease? Organic GI disease like inflammatory bowel disease. How to differentiate? So diarrhea can be seen in both of them, both irritable bowel syndrome and organic GI disease. Abdominal pain can be seen in irritable bowel syndrome and organic GI disease. I have taught in my lectures about the criteria for irritable bowel syndrome, which is the Rome 4 diagnostic criteria. I hope you remember the Rome 4 diagnostic criteria. Next, mucus in stools. Again, it is a feature. It can be present in both irritable bowel syndrome and organic GI disease. But option C, stool calprotectin, this would be a feature that is, it is a marker of inflammation. This would be a feature in inflammatory bowel disease, IBD, and not IBS. This is a feature of inflammatory bowel disease. Okay, right. Next is, so that is option C is the answer. Next is liver biopsy is given. So maybe the clinical scenario of a patient with liver cirrhosis. And in liver cirrhosis, the biopsy is showing a Pearl's Prussian blue staining. And you can see this is staining is positive. What do you think is this condition? When you get a positive staining with Pearl's Prussian blue in a patient with liver cirrhosis, what could be the reason? Very good. As in the comment section, Sean, it is hemochromatosis. Hemochromatosis is the answer. Hemochromatosis is the answer. Okay, very good, very good. So that is correct. Okay, hemochromatosis is the answer. So in the last 3 hours, I think it has been exactly 3 hours that we have started. I hope I have been able to give you a comprehensive overview of medicine. We have covered so many important points. And I hope that all of you have made a workbook which is going to help you for the exam. So many points from various systems we have covered. These are all high-yield points which I have collected from the last many years question papers of FMGE, like often repeated areas, renal tubular acidosis, multiple times they have been repeated. So what I tried to do is, rather than a very detailed, elaborative teaching session, since you are looking for revision content, concise, crisp content, I have tried to give you exactly that. So you can share this video also with your friends who are preparing for the FMG exam. If they are looking out for some concise and crisp content which will help them in the revision before the FMG exams. Okay, so I hope it has been clear for all of you. And all of you should have the confidence within you. See, I know many of you tell me, sir, dar lagta hai because exams are approaching. I'm getting scared. I have not prepared. See, it is not like that. All of you have put in genuine effort. You have all tried well. You have put in so much of hard work. I know how much of hard work the foreign medical graduate students you put into your exam preparation. So please understand that there are 19 subjects. Portions are vast. That is okay. But you know everything. You will remember them. You will remember them when you see the question with the options. Please don't panic. If you don't panic, if you keep yourself calm and relaxed, you will be able to answer most of the questions. I'm not saying you will be able to answer everything. Remember, we are all human beings. I'm not giving you any false assurance that you will be able to answer everything that you learned. Everybody is a human being. You are a human being. I am a human being. We all might forget a bit. That is okay. See, for you to crack the exam, you need to get 150 plus. So you target 180 plus or maybe 200 plus. But nobody will be able to score 280 plus, correct? No. So that is because everybody will forget. Whoever is going to get top rank also will forget. Okay. If you are a human being, you will forget. If you do not forget, that means you are not human being. Okay. Everyone will forget. So don't be too much anxious. All of you stay relaxed. You try your best. In the remaining days, I want all of you, number one, to have confidence in yourself, belief in yourself, faith in yourself. Keep yourself calm and relaxed. Faith in your class notes. From whichever notes you have prepared, have the faith. Have faith in your teachers, all your parents. Your parents are also praying for you. So you have got support of everyone, your parents, teachers, your friends. So don't worry. In the remaining few weeks, I want you to be relaxed. If you are relaxed itself, half the worry is gone. So that is it, my dear students. You might say, sir, medicine is very vast. I will not be able to complete. At least cover whatever I have taught you in the revision video. In this revision program, that you have to cover. They are very, very high yield content. So this is the QR code of my Instagram page. You can stay tuned to my Instagram page for academic updates. And I wish you all the best for the FMG exam on behalf of all faculties of DocTutorials. In DocTutorials, all our faculties, they have put a lot of effort to make your exam preparation journey easier. So we have got, these revision programs. We are coming up with, the most important question session series. We are having grand tests with video explanations. You please make use of this. And I wish all of you all the best. Thank you so much, everyone, for joining. Arun, Jay, Rupali, Priyanshu, RG, Said, I wish you all good luck for your exams. And I hope that after your exams, you will be messaging in a happy note, sir, I have passed the exam. Because you have put in so much effort, you deserve to pass this. All our prayers are with you. The entire team of DocTutorials, all the faculties will be praying for your success, and keep watching other revision videos in the DocTutorials platform. Thank you so much, everyone, and all the best for your exams. Thank you so much. Okay. Bye-bye, everyone. Okay. Thank you so much. Thank you so much, everyone. Deepu, Syed, thank you so much. Thank you. Thank you so much. Thank you so much.
Recording stopped.